Great. Okay, thank you. Yes, so as Carol mentioned, the MRC network of hubs for trials methodology research, which began in 2008, funded some projects around the issue of oversight committees, including trial steering committees. The hub network has now broadened into the Trials Methodology Research Partnership and involves several networks, organisations, and indeed 25 universities. And we're based around, or we work together through 8 working groups, and the work on TSCs is still very relevant, in particular to the trial recruitment and conduct group, but not exclusively that group. Anybody who's on the workshop today is more than welcome to join one of those or more of those working groups. The eligibility criteria is essentially that you are interested in trials methodology and active in methods research. So it's been mentioned already, and I won't read out this full slide, but essentially the network were speaking to funders, NIHR, CRUK, BHF, and it became clear that TSCs, there was some variability, and it was of interest to try to look at this as a topic, try to understand the roles for TSCs. And we funded, from the Hub Network, we funded a project led by Carol on updating and redeveloping guidance. We funded a project led by Athene on an interesting ethnographic study looking at group decision making. And then finally, there was a co-funded project with NIHR on a TSC charter, and you'll hear from each of those projects later today. The Hub Network started running workshops which were entitled How to Be a Good Chief Investigator, and they were run multiple times with good feedback. We have a template for those workshops for anybody who is interested in running one of those workshops in their local region. And from that, we were speaking to Hal Williams at NIHR, and he'd heard this great feedback from those chief investigators who attended, and actually thought there might be an opportunity to run a workshop on how to be a good TSC chair. So the NIHR CTU support funding was provided in 2020 to Carol, Athene and Matt. And indeed, the NIHR suggested a virtual workshop for 2021. This was before the pandemic happened. So there you go, there's foresight, and that's why we're here today. So I was asked to very briefly summarise my experiences of oversight committees, and this started a very long time ago in my experience as a trial statistician. And essentially, as a trial statistician, I had to be prepared to talk through the report and answer questions. And I soon realised that the trial team was extremely close to the study. And as a trial team member, you really need to expect and be open to constructive criticism. As a CTU director, I realised how difficult it was to identify members to sit on oversight committees, including TSCs. So I'd just like to thank all of you who are willing to do that. I know many of you have sat on many of the trials run from Liverpool, so thanks for that, and thanks in general. My experience on IDSMCs, I found that my role, both as an independent member as a chair, I actually found more clearly defined, but it can also be more challenging. And as a TSC, I've been a TSC independent member, and I'm also a current TSC chair. And what I had wished I'd known at my first TSC meeting as an independent member. So it would have been great, it's many years ago now, but it would have been great to understand the role expectation, both from the trials team perspective and also the TSC perspective. Would have also been helpful to understand, what does being a critical friend mean in practice? Now, one of the things that I've learned from being on a TSC as an independent member, firstly, TSC style and way of working varies. Secondly, that many people on TSCs, many independent people on TSCs, are unsure of their role. in particular, I think it's really important to consider the sort of preparatory work for patient and public members of the TSC. And I noted actually in my inbox this morning, there's been a recent publication on that. So I look forward to reading that with interest. On a personal note, I think it's actually quite helpful to get approval for the protocol with the TSC and the IDSMC in advance of HRA submission. But I think most importantly, as a TSC chair, but also an independent member, I think it's really important to praise the trial team as they work to address challenges, even if they're not successful. Because once you've been involved in running trials, you know all of the challenges that are going to arise, and you know how important it is to address them. And I think that TSC members should never forget how difficult it is to run trials and should always praise appropriately. Thanks.
I shall be presenting on Trial Steering Committee research, including the role of chair. I'm Athene Lane, based at the University of Bristol, one of the organisers of this workshop. Now, the background to clinical trial oversight is that, perhaps as we all know, the MRC produced some guidelines for good clinical practice in 1998. This was the first guidance on TSC remit and structure, and they produced a brief terms of reference for TSCs. However, there was never any formally published TSC charter, and the terms of reference, role and functionality have not been widely distributed as a result. In contrast, the Damocles project, DMCs, these various acronyms, they published a data monitoring charter in the Lancet in 2005, and that is well established and referenced worldwide. In more recent times, in 2017, the MRC produced guidelines for the management of global health trials, and this included a trial steering committee. Just to remind again, there were two MRC-funded HTMR TSC research projects, one led by Carol Gamble on TSCs for RCTs, and a second linked one led by myself and Ali Hewood, and that was an ethnographic study on group decision-making and trial oversight. I'm just going to summarise the key points of these research findings and bring them together in hopefully what will be useful hints and tips, as it were, findings for TSC chairs. So in the first paper, we took a cohort examination of RCTs, which were from the major journals and the HTA monographs, and the key finding of this was that the TSC was only really mentioned in about half of the trials. The funder role in those oversight committees was entirely unclear, and there was a wide variation in naming, things such as trial executives, steering committees, management groups, etc. And the members also seemed to vary widely from 2 to 52, and the membership of the constituent parts was unclear, and also the independent. So the upshot of this was that understanding the benefits and impacts of the trial steering committee using a literature-based approach was really not very feasible. Secondly, we took a survey of trial steering committee and also the clinical trials units, and we asked them what they were doing, how they used trial steering committees, and if they had terms of reference. And we asked them to provide them if they would. And we got 21 of those terms of reference and 38 of the 47 CTUs at that time. And the key finding of that was that, yes, there was widespread adoption of the MRC guidelines for clinical trials, and their terms of reference were being used in many of the trials units. And around half of those that sent the documents found that's what we found. However, the conclusion was that in the comments and the free text, trials units were finding the terms of reference useful, but updating and limitations, things had moved on, needed to be addressed. In this third piece of work, we drew together all the findings and we constructed an expert panel which Carol Gamble organised, and that brought together trial steering committee experts with experience in various roles as well as methodologies. And that was held in Edinburgh. And the results of this, in brief, are that we got good agreement on what the actual role of the TSC was, its accountability, membership, definition of independence, experience, which was definitely required and training was needed. However, it was noted that none had been provided. Needing more guidance, examples to define further were the management of tricky ethical issues, difficult or complex situations, and issues which were felt either to be or not to be for the DMC recommendation. There were a number of additional topics that had become more pertinent recently, such as data sharing requests, indemnity, the lifespan of the TSE given data sharing, etc., the administration, who did what, and funder and sponsor roles. We'll come to that a bit later. And it's just to note that we did not discuss PPI in this particular panel. Turning now to the ethnographic studies, there are 3 papers relating to that, which I'll summarise. And this took a slightly different approach. The methods were to observe and audio record 8 trial steering committees and TMGs of trials that were undergoing challenges. And we undertook 65 interviews with 51 independent and non-independent members, statisticians, sponsors, funders, reps, and chief investigators. The results of this first paper highlighted that the key roles of the TSE were valued. The first role was that of quality assurance, and patient advocacy was the other second key role, and it was deemed that that was the paramount function of the trial steering committee. The chair and the independent members were critical to the success of the TSE, and I'm going to pull out a few more points on that, which might be helpful later. And independence was also regarded as being important for the impartiality of the advice that was received. However, it was noted that there was difficulty operationalising the definition of independence of some members. In our second paper, we looked at interrelationships between the committees, and the results of this were that there was a need for clear communication lines between all oversight committees, and there can be and had been problems when this wasn't well defined. The clinical trials units themselves could take on a role to help communication between committees, and the trial manager often acted as a first point of contact. TSEs did use DMC guidance in their decision making, of course, but it's fair to say that they didn't always, and recommendations might differ. And also there was an interesting point whereby the primacy of the trial steering committee was potentially being reduced or altered by their greater accountability to some funders and sponsors. So just here now, just drawing out a few things from those studies that I think might be helpful towards TSE chair, examples of key features and good practice. Again, to reiterate, the main role was as a critical friend or provider as tough love. So the words of wisdom that we give, they may be words they don't want to hear. Meetings are conducted in a friendly environment, but we are there as advisors and critics. That's a good summary from that TSE chair. Their impartiality was valued. Independence was key. I would have done anything not to have the trial stopped. Really, it was correct that it should have been as per protocol. Experience was valued for the TSE chair and independent members in 3 really good areas. Firstly, their own experience of conducting trials. They brought a different view of the world to suggest solutions from your past experience and past knowledge. The oversight experience of being in clinical trial oversight, and it was often noted that a sort of apprenticeship model could work well. The CTU director notes the easiest way to get this experience of this as trial oversight is as an observer or a non-voting member of a TSE. And this was said by a number of different people. And if you're aware of that from the other side of sitting on a TSE, you think even harder before you overturn the DMC decision as statistician. And finally, that broad view was valued that the TSE chair brought to the trial. The TSE does not have to take the DMC advice because it has to see a greater picture. It almost certainly will. That's an independent member. Second set of advice here for the chair, the independence always came to the fore. But I think the chair and the independent members do potentially can draw a bit of a tricky path, and this quote summarises it nicely. On the one hand, you don't want to be completely dogmatic. You see a car crash 100 yards down the road, you don't sit on your hands. But on the other hand, you do have to be careful that you don't roll your sleeves up and without really realising, change your role from being an independent TSC to another organ of the research team. The role was seen as being the critical advisor to, quote, scratch the shiny surface of TMG member notes in the thought that the trial team might try and put forward a good and better than what it was sort of view of how the trial progressed. However, this quote, which I still love, my favourite, the trial steering committee should probably be able to deal with that. And this quote summarises, I would like to think that those old goats that serve on these things are long enough in the tooth to see through that rubbish. And the whole conduct of the meeting, the debate and the openness were important to encourage. So I think that the best kind of TSC is a good compromise between a genuine sense of open debate and inquiry, but it's based on rock solid data, which has been produced to a professional standard. And the openness is noted by the sponsor. What you need is a very open culture to do that, because it's the responsibility of the trial team to bring to the TSC those issues as they arise. I've not touched on PPI involvement in trial oversight up to now, but there has been a suite of research, starting with the original Carol Gamble work, which looked more broadly across clinical trials. Ourselves, through our interview and ethnographic work, we also drew out the public involvement in trial oversight. I'll just mention that briefly. And then there's been a third piece of work conducted by NetCC, which I think we will hear about later, so I won't go into that now. Turning to our paper, in our paper we did find some interactions that were helpful and hints for the chair. The role of the chair was important in PPI, and that was referenced a few times. It was noted by a statistician that TSCs have a lot of rule. It's quite formal. It was noted as well that it's quite an academic environment, which could be complex and difficult for PPI in some cases. An active chairing style was seen to be the way to go to address this issue. We went through, unlike this one, which is quite brief verse, we went through the last agenda items as if they weren't there, including the patient representative. The chair didn't even mention it. But the time was pressing and chair didn't keep to time. PPI representative. Inclusive of PPI, you need to have a TSC chair drag views out to them and specifically ask what they think and for their contribution. And then finally, we've drawn together all our research and others and produced a commentary, a relatively recent commentary on trial steering committees. And this was produced by Carol, Matt and myself, working with Doreen Temper and Craig. In that, we summarise the benefits of the third oversight committee. We highlight the challenges and recommendations for operationalisation, particularly in the modern era with changes that have occurred. And we highlight that there's a clear need for revision of the TSC charge or terms of reference. And we hope that that would bring greater standardisation and adoption. But I'm not going to go into that into detail because Matt will hopefully pick up on this later and give you a little bit more of where we're at with that now. Thank you.
Hello, I'm Andrew Farmer. It's great to have this opportunity to contribute to discussion around trial steering committees. I'm a general practitioner by background and have led clinical trials in an academic role. I've also been a member of research funding committees for over 20 years, and I'm now the director of the NIHR Health Technology Assessment Programme. So I've been on both sides of discussions about the role of steering committees. Here's my disclaimer. I've been asked to offer a funder's perspective on what makes a successful trial steering committee. I'm very much looking forward to the discussion, and I hope the thoughts I can offer now will stimulate that. I'm going to try and share some thoughts around the way that trial steering committees, and particularly the TSC chair, helps contribute to the way the funder monitors the trial. To put these comments in context, I want to start off considering why NIHR funds clinical trials, and particularly pragmatic clinical trials. I thought it might be helpful to start by giving some background about HTA. Like all funders, it delivers its role through a number of different activities. These include identifying important gaps in knowledge about clinical and social care. It then turns these into research questions and prioritises them and runs funding competitions to allow these important questions to be answered. So the NIHR needs to keep track of progress of this research and work with researchers to deliver the research findings and see that they are widely disseminated. To answer the question of why we do trials, there's probably no better person to refer to than the Chief Medical Officer and current Chief Scientific Advisor to the DHSC. Trials are really useful for changing clinical practice. The HTA programme has been funding clinical trials with the aim of providing evidence for patients, clinicians and policymakers. Trials can indeed give quantitative answers, but to do this they need to be designed and carried out rigorously with careful oversight. That oversight needs to be independent of any conflicting interests, and the Independent Trial Steering Committee is a guarantee of that. The foundation for clinical trial conduct is, of course, the Declaration of Helsinki, adopted in 1964. As far as I'm aware, the first funder-led guidance for clinical trials in the UK was issued in 1998 by the Medical Research Council. This comprehensive green booklet included advice about the composition of an independent trial steering committee. The HTA programme based its own guidance on these guidelines and in turn, with minor adaptations, the DHSC based its guidance on those HTA guidelines in 2005. Other UK funders have come in with their own guidance. There are some minor differences, but the aim remains the same. To provide independent supervision and ensure that the research is carried out rigorously and safely, and to provide advice to the chief investigator and other responsible organisations, including the funder, on all appropriate aspects of the project. From the funder's perspective, this oversight is essential to ensure that the evidence provided by the study is seen as credible and trustworthy, and that the study has used public funding responsibly and carefully. The role of the Trial Steering Committee in acting on behalf of the funder and ensuring that the research is carried out within a nationally agreed framework for health and social care published by the HRA is specifically laid out in NIHR guidelines. These guidelines are available on the internet and set out the purpose of the Trial Steering Committee, how it's appointed and its role. They're part of the wider governance about the way the study should be carried out and the role of other guidance committees, including the Data Monitoring Committee. The NIHR guidance, in common with other funders, emphasises that the role of the TSC is to provide overall supervision on behalf of the funder. Given the use of public funds and the need to provide reassurance about credibility of the findings, the independence of the TSC is essential. The guidance also points specifically to the Framework for Health and Social Care. The document is sponsored by the HRA and the Scottish and Welsh governments alongside the DHSC. So the framework sets out the responsibilities for research and the principles that should underpin the way it is carried out, particularly in relation to patient care. The NIHR guidance for the role of a trial steering committee is straightforward: to concentrate on the progress of the trial, adherence to protocol, patient safety, and to consider new information, and importantly, to consider the safety and well-being of participants. Substantial protocol amendments need to be carefully considered and their potential for undermining the integrity of the trial thought through. For example, changes in outcome measures or trial inclusion criteria can change the effect size of the intervention, with knock-on changes in the number of participants needed to be recruited. The TSC needs to provide independent advice to the sponsor and funder about those proposed changes. Over the past 18 months, as a result of COVID, there's been a large number of studies of the HTA programme where researchers have worked hard to keep things going. For many of those studies, the clear support from the TSC for a well-considered proposal that does involve changes in things like the way that the intervention is delivered or the way that outcomes are measured has enabled those changes to be supported quickly, easily and without delay. It's really important to have an independent chair for a trial steering committee. As with any research-related activity, it's not just the presence of a conflict that can cause problems, but the perceptions of conflict. And while most of the time there isn't a problem, there are occasions on which, for example, when concerns about safety of an intervention being tested are raised, where a trial steering committee needs to be seen as independent and not compromised by a close relationship with the chief investigator or by being employed by an institution that would benefit in some way from the study. Most of the time, the trial steering committee members and chair are nominated by the chief investigator and approved by the funding programme. There are occasions, particularly when the funding committee has raised concerns about equipoise in the research team, or perhaps the presence of a financial interest around an intervention such as a diagnostic test, that the funding programme will nominate an experienced trial steering committee chair, and this then needs to be agreed by the research team. I've met many trial steering committee chairs in the course of face-to-face and video calls. By and large, they are hugely experienced and able to offer a considered view of progress and what is happening. Occasionally, though, it's clear that the TSC chair considers themselves a member of the research team. For example, I've heard discussions in which it's clear that the TSC chair has been closely involved in operational meetings to plan the change in the protocol and has even presented the research at international meetings. This can become a problem, particularly if the study is encountering difficulties. The sponsor and the funder need to know that the recommendations of the TSC are not conflicted. The TSC chair can provide much better support to the team and much more effective support if they are seen as independent. The NIHR have set out the roles that a TSC chair should offer on their website. I think I've covered most of these in passing already, but it's worth emphasising the way that an experienced trial steering committee chair can provide an independent opinion where problems arise. Knowing how previous research teams have responded and the capacity to set out objectively a framework in which ideas and proposals can be set out clearly is absolutely invaluable. Most multi-centre clinical trials encounter some form of difficulties, whether at the stage of an internal pilot or where decisions need to be made about continuation of the study, or when recruitment has been challenging. Decisions need to be made by the funder about continuing or stopping a project, and an independent TSC chair who can be trusted by both the research team and the funder, and who is in a position to ensure that all aspects of the problem are considered in detail, can allow the best decision in the circumstances to be made. A good TSC chair can take a considered view of an extension or close down. The funder doesn't want to see an enthusiastic advocate who is uncritical of problems encountered, nor someone who is unable to break the bad news to a chief investigator that this project isn't going anywhere. It's really important to bring all the perspectives together and facilitate debate within the team. I know that a discussion on the role of patient and lay representatives is on the agenda for later in the day. However, I couldn't go without highlighting the role of PPI on trial steering committees. The last 20 years have seen expectations and practice evolving in this area at a huge rate. At best, having someone in the room who asks questions from a patient's viewpoint is invaluable. HTA and NIHR have been at the forefront of supporting PPI involvement in all stages of research, and for that matter, all stages of the research funding process. I wanted to finish with a couple of personal reflections. My first experience of a trial steering committee was for my first project as a chief investigator. My mentors and experienced colleagues pointed me in the direction of a wider respected trialist who took on the challenge. The guidance and support I received was absolutely essential, not least in ensuring the rigour and detail of the documentation needed for that trial steering committee. I hadn't realised the value and importance of what the experienced chair could bring. I still remember my first attempt at a draft agenda and set of documents for that TSC, and them being picked apart firmly but kindly. I often wondered how I could have managed things better. I could have been an observer at a trial steering committee, and indeed I had the chance to join other TSCs shortly after that as a member. But being an observer wasn't then usual, and it still raises issues and concerns. But wherever possible, I encourage junior colleagues to join meetings and understand the process that's going on. Secondly, I wanted to reflect on my experience as programme director, and before that as committee chair, and before that deputy committee chair, where I had frequent meetings where I first of all looked through minutes of trial steering committees and then met with the research team and the trial steering committee chair. Out of the very many examples of best practice, there come some things that stand out as really excellent, and these include concise documents without unnecessary detail, easy to understand documents, and charts that are easy to understand, making clear the differences between goals and performance. A good trial steering committee chair is, I think, essential to ensure that the team can objectively present the facts of what's been going on and what their plans are to overcome the difficulties and challenges being faced. The funder, after all, wants to see the important research it is funded completed. Thank you very much.
Hi, and thank you for inviting me to share my sponsor perspective of a successful trial steering committee. I'm Birgit Whitman and I'm Head of Research Governance and Integrity for the University of Birmingham. Most of you will be familiar with the role of the sponsor, and I've put up there just one definition. For me, it is one of the most important things to ensure a positive research culture in line with the expectations of the Concordat for research integrity. And equally important is to ensure that we enhance research quality and safeguard the public by appropriate sponsorship support for study. At study level, the sponsor responsibilities are covered by pre-award and post-award activity. Pre-award, usually at funding application stage, it's to ensure that the study can actually be ensured and we can have appropriate indemnity in place. At the time when the funding is awarded, we would look to ensure that there has been an independent peer review and, where necessary, risk assessment to give assurance that there has been more than just a study team assessment. We also look to the deliverability of the protocol. So have we got the right competences in place? Is the right infrastructure in place? And we will give some guidance in relation to the research ethics review process that should be undertaken. One of the key things for us is ensuring legislation and appropriate regulatory approvals and making sure that we have good contractual relationships with all stakeholders in the study. Of particular interest is the plans for sample management and data management, and we do have a careful view to the conflict of interest, financial probity and management of IP. When it comes to the publication of the study results, there are increasing demands on trial transparency and reproducibility, and we look to the plans of how the research team wishes to disseminate the study and how the impact can be maximized. As a sponsor, it's all about risk management, and we do look to TSCs to support us with that. So for me, it's about the quality assurance processes that a study has put into place. It is about risk assessment review, and clearly that's a moving feast, so this can change. It's making sure that there are risk-based monitoring plans in place before the first participant is recruited, that there is appropriate pharmacovigilance, and one of the things we really are reliant upon is the annual reports that are made to the Research Ethics Committee on the annual safety report to the regulator. And of course, occasionally we might be subject to statutory inspections by regulatory bodies, the MHRA and the Human Tissue Authority. So the sponsor representatives usually work closely with members of the research teams or colleagues in the clinical trial units. But we really do rely upon members of the trial management group to manage the day-to-day delivery and conduct of the study. And obviously for some studies, members of a data management committee will review safety and efficacy. As a sponsor representative, we cannot be experts for every study, and we rely on TSC members and the TSC chair to make recommendations in relation to issues that arise about deliverability of a protocol, or if there are safety issues with participants, and potential integrity of data, reproducibility issues, trial transparency issues, and more recently, finding a way of making trial information appropriate for the participants to understand. So in my practice, the input from TSCs has been particularly helpful when we at the stage of developing the protocol, where we rely on members to identify potential issues with delivery. It is also about having a good a funder relationship and ensuring that the study is delivered in line with expectations. We at times have to make decisions about stopping and restarting a study or a certain study arm in the case of safety concerns or IMP, and here particularly the expertise of the TSC members and the independence of the TCA members is of high value. Occasionally we have to manage plans for early study closure as a result of those issues, and that needs careful consideration and input from TSC members, and of course in the preparation for publication and examination. Thank you very much.
Okay, thank you. So we can move over to some questions now that we have around these two presentations. So there's a number that have been posted within the chat. So I might just start with one of those. And possibly this one is for Andrew. Very often the chief investigator is a strong character. Any tips for a TSC chair interacting with such a person?
No, that's a really good question. I think it's possibly one of those occasions where actually you have to get the right person as the TSC chair. So someone who is independent, who can actually, a strong character might well try to sort of suggest to the funding body someone who actually is already someone they work with, or they feel they have a good relationship with. And I think that's the point where actually having someone who can step back and actually come in and not get too close and sort of work with the data rather than necessarily with the relationships is a useful thing. So it's often, I think perhaps the answer to your question is stick to process. Make sure that there is a very strong agenda, very strong reporting, run the meeting so that they actually report on things that are agreed in advance, and that perhaps is a way to ensure that the discussion goes along a very clear route that addresses the roles of the trial steering committee, rather than, you know, potentially gets sort of sidetracked or elided into other issues. But you know, it's a challenge in every aspect of our life when you're trying to do something different.
Yeah, I think that follows on to another question that got posted by somebody who has a TSC chair who is wanting to review safety data, which is clearly the role of the data monitoring committee in terms of trying to make sure that the TSC remit is very clear at the start of the study, rather than making sure that the boundaries in terms of what they would review and what they wouldn't review are quite clear. Another kind of difficulty that we've seen in a few TSCs is around the fact that when the chair has been appointed and they're not necessarily completely behind the trial as it has been designed. So by the time the TSC chair has been appointed, it's been through, say, your NHR peer review panels, the funders have agreed the feedback. As it stands, it's, you know, the trial is designed as funded, and then maybe they come along and say, I can't believe this has been funded at 80% power, it clearly has to be 90%. Do you ever get those situations with between the TSC chair and, say, the chief investigator and their team, in terms of the agreement around what's being funded and why?
I've not seen them bouncing back up to the monitoring team at HTA, let's put it that way. Okay. I mean, I think that is, I mean, that's a situation where actually you'd hope that the chief investigator would have picked someone who might be happy with you know, there's always an issue once you put, there's a gap between the grant application and writing the protocol. But the things like, you know, how it's powered and what the outcome measures are usually not things that are open for discussion at that point. There's, you know, huge sort of operational things and sort of refining it that are necessary for the trial steering committee. But that's a strange one that I would have thought to come up. But you know, I think in terms, so, you know, the principle that I put forward is that you know, we'd normally expect the chief investigator to propose someone, and you know, unless there were good reasons, one would want to accept that as a funder. You know, the only reason we wouldn't is if you know, we had other concerns about the study and about equipoise and those aspects of it. But you know, the whole point of this is to keep the design simple and to make sure there's clear you know, boundaries for running a trial.
Thank you. Birgit, you Andrew mentioned that one of the problems that they sometimes see is that the TSC chair becomes a bit more engaged with the trial team and maybe becomes more of the trial team than retaining their independence. What kind of the common problems that you see as sponsor?
So to be honest, I don't see that many problems with our TSC, and I'm very grateful for all the interactions that we do see. And I think we're lucky in as much in Birmingham we've got the clinical trial units, and of course it's managed very well by colleagues from the clinical trial units. And I really am almost a sideline player. But when it does come to big decisions about the trial, so let's say there is a problem with an arm. I put a few up in my presentations. You know, this is not my expertise, and if I just have the view of the research team, then I would feel I don't have a rounded view necessarily about the issue, and should we stop completely? Should we temporarily pause? Should we restart? On what conditions do we restart? And those sort of things are incredibly valuable when they get discussed at TSC level. And very often I just see the minutes of those meetings coming through to give me the reassurance that I have. Mm-hmm. Occasionally, we will have a meeting, and so if it's a really complex decision, then we'll sit together. But I think everyone there has a role to play. So we have our chief investigators, we have our clinical trial units, we have our trial management groups and DMC and then the TSC. But ultimately, I think if I would feel uncomfortable, my view would be to go first to the TSC chair and say, okay, so I've seen what's come through from the research team, I've seen what's come through from the CTUs. I have a concern in relation to whatever. Can we discuss this? So I think that would be my port of call for independence. And as a sponsor representative, I always say this. So ultimately, I see myself in court having to defend a decision I've supported as a sponsor, and I need that level of independence to give me the evidence, sort of like a 360-degree view on the issue, and then I can feel confident that we've done everything we can. That might still not be the right thing, but at least we've done everything we can to come to a sensible decision.
Okay. So that definition of independence, someone's posted a question around that as well, in terms of how do you define that independent? And I know that NIHR have got particular guidance around that definition, which sometimes it's quite challenging to use operationally. And someone has asked, is it okay if you've worked with them before? So as an example, statisticians, it's quite a small world, and if you were trying to narrow it down to people that you hadn't worked with before, you wouldn't necessarily leave you with being able to choose the best TSE chair or TSE member for your trial. So what are your thoughts around flexibility on that, in terms of how you've worked with them, how long ago you worked with them, and so on?
So from my point of view, the most important thing for me here is the expertise. So I think if you need a certain expertise on a trial, and maybe it's a very specific area and there are not that many choices, then actually I would always go for the expertise, and we can have an open discussion about the conflict of interest or the integrity of what I need to see. But I think it's more dangerous to have non-expert people advising on something which is maybe just remotely related to their area, than actually having the expertise and manage the conflict of interest or potential conflict of interest. I think as long as that's transparent, so I'm clear that there is a long-standing relationship, a good relationship or whatever, and we have certain frameworks around that, I would feel much more comfortable going with the expertise rather than not.
Okay, so one of the a couple of questions are related to, are there instances where a TSC isn't needed? So Andrew and Birgit, what are your thoughts on that? So as an example, diagnostic studies, do they still need a TSC?
Well, I think that if there are decisions to be made around a protocol and the viability of the study, I think it's really helpful to have an independent group. Now, that doesn't mean to say it has to meet every 3 months and spend a couple of hours. I mean, you can have a very light touch setup to handle the issues, but I think it would be, we're not talking about data monitoring committees. I mean, I think there are circumstances where one can be flexible about that. But I think if you're dealing with I think the occasion where perhaps trial steering committees aren't necessary are at the feasibility stage. Where one is trying to sort of set out the parameters for a larger study or do some experimental stuff. I mean, I think it's always good to have some external advisors, but whether it needs to be formally constituted is a different matter. But I think once one gets into larger multi-centre studies, I think something that's proportionate, but nevertheless there in case there are problems, is useful.
Okay.
I think for me it's about the complexity and risk. I think so if it's like, I mean, I completely agree, feasibility, we wouldn't move into that space, but you can have so either you have a study where there is a considerable number of risks you want to see managed with independent input, then I definitely would like to see that. or it's a very complex trial design where maybe the risk is not massive, but the complexity of the trial design is very unusual, or whatever it is. Then actually I think I would want to see that too. So especially with COVID, we've moved into quite unusual trial designs, and I think because we are at the very early stage of the experience there, then actually it's quite nice to have a more rounded view on that, if there's a possibility of putting a TSC in place.
Okay, so there's a couple of questions here relating to communication between the TSCs and DMCs, in terms of should they be able to communicate directly, or should they always use the kind of trials unit as the go-between for them? So I think direction of communication is something that Matt picks up on later this afternoon, but yeah. So
for me, because I think it's important that the channels of communications are managed appropriately, and I wouldn't want a situation where only half of a group of people will see some information and the other half doesn't, or something. So I think I would rely on the organization skills of the CTU to actually facilitate those conversations. I think if then the chair of DMC and TSC know each other and have an offline discussion, I think that's okay. But I think any official discussion and decision-making processes, I would want to be really transparent and recorded. And therefore I would rely on colleagues in the CTUs to facilitate that in the effective way they are actually trained to do this. So yeah.
Okay, Andrew, your thoughts on that?
Yeah, look, I mean, the important thing is that there's clear, open, transparent communication that's set out in advance. So, I don't mind whether the trial steering committee charter says that the DMC chair writes to the TSC chair and the chief investigator, copying in the funder and the sponsor, whatever works best. But as long as it's clearly set out and stuck to, and that there aren't sort of other channels of communication is the important thing. So, define it in advance, and if it works for an institution or it's sort of set out clearly in some guidance, follow it.
Okay. And then I think the last question before we potentially go for the break is, can a chair ever be overruled on a decision?
Okay, for whom? So I think for me it's who would overrule the chair. So I would never overrule a chair lightly. I think the only thing, and this comes back to the situation where I think I would seek a discussion and a meeting. So clearly we have a legal team in the university, and for some cases our legal services team has to be involved in the decision making. So if there was a very strong feeling for legal services that we could not proceed with one thing or another, but the TSC would feel differently, I think we would have to have a discussion. But ultimately it is my view that if the decision is the institution cannot support this on this basis, i.e. as a sponsor representative for the institution, I'd have to say no or yes, whatever. Then actually, I guess the sponsor decision could overrule a TSC, but that should never be done lightly. And that would only be if there is an institutional reason why we couldn't support it. Okay.
Andrew, from a funder perspective?
From a funder perspective, I mean, I think that would be, what you're expecting from a chair is someone who will actually bring together a view from the independent steering committee. So, one would hope that they're not coming up with a view that is so clearly divergent from everyone else that it's going to create a problem. I mean, what you're suggesting is that they've fallen out with their committee, who are all saying one thing and they're saying another. I mean, you hope you never get into that situation, but if it was, then I think it's actually almost a matter for the sponsor rather than the funder. I mean, what the funder wants is a clear view of what the way forward is, and if that's not coming out of the TSC, then one would hope that could be resolved locally before, we get pulled in. I mean, the funder will, if there's a decision to be made about the contractual issues, which is where, one comes in as a funder, then, there may be other ways to make that decision than relying on what the opinion of the TSC chair is. But if not, then it's very much a sponsor issue, I would have thought.
Okay, and then I've just seen one last question there that relates to independence. So I'm just going to flag this one before we break for a comfort break. Can I chair a TSC for Dr. X's trial if Dr. X is currently on a TSC for my trial, or does that compromise independence?
No, I would have thought that's absolutely fine. I mean, the whole point is that you're both independent from each other. I mean, you're both there as an independent person, so I wouldn't see a conflict with that. It's much more if there's a personal, or you're working together, or there's a financial link or an institutional link. But just happening to be both being independent, I mean, that's the way there isn't a connection there. You're both independent in both roles.
Okay, well, I think there are many statisticians everywhere breathing a huge sigh of relief, because that's how we very often get statisticians on TSCs, is I'll do one for you and you do one for me.
That seems completely sensible.
Okay, so it's just time now ready to break. So I just want to say a huge thank you to Andrew and Birgit for presentations and staying for the Q&A as well.
Hello. Thank you for the invitation to come and talk to you about my experiences as a TSC chair. By training, I'm a statistician, and I've spent a good part of my life doing trials and being involved with them from many perspectives. I've been a co-investigator where I have designed them and working with clinicians and then running them with trial teams. I got involved fairly early on data monitoring committees, including chairing them. And so in that role, you interact with the TSC chair. I've been a TSC member of several trials and chair. And I've also got a bit of a perspective because I've spent some years as a trial funder, where in monitoring the progress of those studies, again, interacting with the TSC chair is pivotal. So if you're asked to join a TSC, what's the job to be done? Well, the Trial Steering Committee is usually the senior oversight committee. So if you're a member of that, you're taking on quite a key responsibility. And if you're asked to chair it, then you are chairing that senior governance committee. You may think that you've been suggested because the trial team like you, but actually, formally, you are often appointed by the funder or the sponsor, and that is your primary responsibility. This is an independent role, and so if things go right, it may not matter very much, but if things go wrong, you need to look at it from the point of view of the person who's appointed you. And you're often the means of communication with the data monitoring committee, with the trial management group. So there's a number of formal roles. So how do you prepare for that? Well, at the beginning, check you know how the trial is operating. Different trials and CTUs have different modus operandi. One trial I was asked to chair a TSC and I thought, yep, this is straightforward. But actually, when I looked at it, it was a combined TSC and data monitoring committee, which for some early stage trials can work well, but in my opinion wasn't right for this trial. So we had discussion. To cut a long story short, we ended up decoupling them and I chaired the data monitoring committee, someone else chaired the TSC. So I'm very glad we got that sorted out at an early stage. Work out and be clear who is a TSC member, who is an observer. Sometimes the TSC members are just the independent members and others come along as observers. Other times it's a more combined committee. And again, for day-to-day discussions, you probably barely notice that distinction, but for formal purposes, that's absolutely key. You may find that one of the early items at a meeting is a TSC charter, and it's very easy to think, oh, that's just paperwork, sign it off. I'd suggest reading it very carefully, because you may find that there are some further responsibilities that you haven't fully appreciated. It details what happens when things go wrong. And in talking it through, you'll often realise a bit more about what it is you've taken on. Check who's responsible for minute taking. Often that'll be a trial team member, but sometimes that kind of thing gets forgotten. And again, having a formal record of proceedings is absolutely vital. And certainly as TSC chair, but even as another member, just have to think about the membership. Has it got the right kind of clinical membership? If there's an adverse drug reaction that you're looking at, have you got the clinical expertise on that? Is there the right statistical expertise? And if you're chair, I'd strongly suggest having another statistician there to more formally do that role. Have you got patient and public involvement in the right kind of way? And check that you've got the appropriate independence from the investigators and that you haven't got anyone on that who's involved in recruitment. Now, this is probably my top tip. At the beginning, I would strongly suggest, if it's not already in the plan, requesting a joint meeting with the Data Monitoring Committee if possible, and before they see unblinded data. The purpose of this is to check common understanding of trial and responsibilities. Sometimes it's very clear what the TSC do, what the DMSC do, but sometimes it's not. And you don't want that kind of confusion playing out if the trial gets to a decision point. And so just that discussion about what the purpose of the trial is, what data is being used for data monitoring, how communications will happen, will get your head into the trial, but also set up good relationships for when the going gets rather more interesting. During the trial, you'll be asked to chair regular meetings. That could be every month, it could be every year. Again, check what it is you're committing to. As chair, you need to agree the agenda. You need to read the papers, and again, query what's not there. So I can think of trials where we've known that there's other research going on and we haven't had a formal update. So I said, can we have a regular report on what other activity is there? Because sometimes that can impact on the trial. As chair in particular, you may then need to interact with the TMG to convey TSC decisions. You may well need to interact with the Data Monitoring Committee chair, so if they make a recommendation to cease an arm, for example, you'll be in communication with them. And also with the funders. Certainly the NIHR do trial monitoring, and when I was doing that, I absolutely wanted to talk to the independent chair to see what their view was of how the trial was going. It's often on a regular schedule, but you should absolutely be prepared for the unexpected. If the unexpected happens, that's when your most important role probably happens. And at the end of the trial, you'll see and approve the results. As someone who's been living and breathing the trial, you should be in a good position to help critique the presentation and interpretation, to give advice on dissemination, and of course, with the trial team, then to celebrate, because it's a long haul and we take our pleasures where we can. So my top tips is stay independent, be a critical friend, but you are not part of the trial team, and that's critical. You don't need to know everything, but it is your job to ensure that someone is on the case. It's an absolute linchpin role, so prepare for it, take it seriously, and then enjoy it. Thank you for listening, and I look forward to the rest of the meeting.
Hi, my name is Pete Barron. I'm from the University of Manchester, and I'm going to talk to you and share a few reflections on how to be a good TSC chair. So I'm a health services researcher and a pragmatic trialist, and in preparing for this talk, I had a look back through my records to see how many times I've taken on the role of TSC chair. I think it's 4 over the last few years, so fairly experienced, but far from a veteran, and really looking forward to the discussions because I'm sure there's loads and loads of things for me to learn. So the first thing in terms of how to be a good TSC chair is agree to be a good TSC chair. It's quite daunting, pleasant, but daunting when somebody asks you to be a TSC chair. It's obviously often a team you don't know too well to ensure independence. And you know how complex running trials can be, and therefore trying to chair and steer such a trial through is daunting at times, but I've always found it an immensely rewarding role. You meet loads of new people, new teams, you learn loads about trial design and delivery. It's not a huge amount of work. The team does the work, you're there to provide oversight, and there's an element of karma to it. You're going to need TSC chairs at some point. So if you offer the opportunity, definitely take it up. It can be slightly daunting, but really, really enjoyable in the main. So the first thing I'd suggest is important is understanding the remit of the TSC chair. Now, often the first thing you'll do is sign off the terms of reference as during the first TSC meeting. So there's written guidance out there, and that can be really, really useful. But of course, it's like academic contracts. That's guidance. It's useful sometimes, but it doesn't cover everything you're going to need to deal with. It's a complicated issue. You've got the team, you've got the DMC, you've got the funder, you've got the sponsor. There's lots of potential people involved, lots of personalities within those, especially within the team. So guidance is useful, but issues develop over time. So you'll sign off a terms of reference and then issues will develop. So it's always something that's a dynamic thing to a degree, and it's just something to be aware of. I think one of the biggest shifts is understanding, of course, you're not there to peer review the design. That boat has sailed. You're there to look at delivery and quality, and that's important and different. Because the design's been set. There may be some changes, but this is really about making sure that design is delivered rather than talking about the fundamentals. So the second issue I wanted to talk about was the key roles of the TSC chair. So the first one's keep to target. So you'll know that when you put in a bid, you make loads and loads of promises, some very specific promises around sample size all the way through to all the other milestones and issues that you're going to deliver on. And I think there's a really, really important aspect of the role of the TSC chair is ensuring that happens, because trials are tough. Teams get exhausted. They're always focused on the sample size calculation, but there's all the other things that need to be done. So it's not just about recruitment, and I think PPI is often an issue here, making sure that the plans for PPI are delivered, and that PPI has the correct level of importance in the trial delivery. It's not just always at the end of the discussions after recruitment and retention have been dealt with. So you really need to work closely with the trial team, make sure they're giving you the right information so that the steering committee can make those judgments, and that you're continually pushing them to deliver what they've said they're going to deliver with this chunk of public money that they've got. So keeping to target is really, really important. The second issue for the TSC chair, I think, is something I've characterised as raising the bar. So obviously trials have loads of milestones, the recruitment target being the biggest one, but partly there's something about pushing for excellence, and this can be quite difficult. Running trials can be exhausting and demoralising. There's a real focus on certain issues, and adding stuff to the trial team can be uncomfortable, but I think there's something there for a TSC chair to raise the bar. To ensure that quality is maintained and we're always adding value. A couple of examples. So all trials are into recruitment problems. They're always looking at different ways to recruit, and something for a TSC chair is to talk about things like studies within a trial or SWOTs to encourage teams to add to the evidence base on that. Another area I'm really interested in is the NIHR's focus on inclusion and representativeness through their include guidance. I assume that almost all bids going into NIHR over the next few years will make fairly grand claims about how they're going to deal with diversity and representation. But of course, when the rubber hits the road and the trial runs into problems, the focus then becomes on just getting people in. And I think it's, again, a role for the TSC chair to remind teams all the time, how can we think innovatively, how can we think imaginatively about raising the bar around some of these issues, so we're not just doing the same trials that we were doing 15 years ago, but we're actually responding effectively to some of the issues that are being raised by funders that are important to them. So to sum up, I've always found being a TSC chair an immensely rewarding experience. I really encourage people to do it where they can. It is part of what I call academic spade work. We all it's like peer review. We all have to do it, but it's a really, really important job, underappreciated, under-recognised, but it really, really is important. It is quite relational. The written guidance and so on is helpful, but it is about dealing with people and teams. So there's something of a diplomat required of the role. And that's just something you have to develop over time. But a really important role, one I've really enjoyed and I've learned a hell of a lot from. I hope those reflections were useful, and I'm really looking forward to the discussions later to hear the views of others. So thank you very much.
Hello, my name is Mark Emberton. I'm delighted to be with you today and recording this, and hopefully we'll have opportunity for questions and answers and interaction within the sessions. So my big thanks to Athene for getting me in on this wonderful meeting, which I think is really needed because we all tend to learn on the hoof on how or how not to do this role. I'm a clinician scientist, so I'm a urologist working in the field of prostate cancer, and I've conducted a number of clinical trials over the years, diagnostic, therapeutic, and more recently trials that have tried to incorporate imaging within the pathway. And so as principal investigator, I have made all the errors possible. In fact, I'm still learning because I'm still making errors in the current trials that I'm running, and hopefully through those mistakes and errors, we can provide a little bit of insight and help to others. So I think it's my role as chair of the trial steering committee for Upstream that caused Athene to invite me. I'm not sure as a model of a poor chair or a model of a good chair. She's yet to tell me. And I think there are three things, and then one other thing that I just want to share with you that I think are important and that I've certainly valued with the chairs that I've had when I've been principal investigator. And there are times within a study where chief investigator, principal investigator role is quite a lonely one. And you know, one writes the grant, one celebrates the award, and then one kind of knuckles down to delivery, and it can be really difficult and long, and many sleepless nights. So my first advice would be to be the independent and critical, but really important, this friend to the chief investigator. So I think as chair, you are the sounding board, you are the person that the chair can go to, that the PI can go to when the PI is not sure about something, wants to share something with you, wants to explore whether or not something should be done. And I think that role is really quite an important one. And I've really valued the kind of phone calls I've had with principal investigator, chief investigators of the past, where we've just talked about the trial, the frustrations, what's gone well, what's gone badly, what we might foresee as problems in the future, and how we might mitigate those problems. And I think those conversations are really useful. They help the chair understand the reality of the study. You know, this is between the lines on the protocol, and I think it establishes that key relationship, which is principal investigator to chair of the steering committee. And I think that's by far the most important advice. So not to depend just on meetings, but to develop a really meaningful relationship, which should be very easy to do. Most people become chairs because they're enthusiastic about the study that they are involved in. My second advice would be to prepare for those meetings very well, and not just turn up, as I have seen some chairs do, not having read all the materials. And actually, it's the pre-meetings that are the important interactions with the trial administrators, trial managers, to set the agenda, set the timings, make sure everybody who needs to be there has been invited, make sure everybody who needs to speak has been briefed. So there are absolutely no surprises. And that means that the meeting can go smoothly and well, and everybody enjoys the process. And for many trials, all the individuals involved in the studies have been working in isolation. The statisticians have been over there, and the meetings are actually important get together, and it's often and so it's really important that those meetings go well and smoothly and are enjoyable and are an exchange of information. It's quite useful also to have some social meetings around the formality, with breakfast or lunch or something thrown in, so that there can be some informal chit chat afterwards. So preparation. The third one is that occasionally, and this is the independent factor, it's very useful to hear the voice of the chair, and sometimes there are occasions that arise where the principal investigator needs a authoritative voice to, it might be to the trial sponsor, it might be to the trial funder, it might be to a partner trust that is being difficult in terms of access to patients. And I think the role of the chair is very useful in actually picking up the phone or writing to key individuals to say how important access to patients is, or the trial extension is for the etc. And I think that role has been very valued by principal investigators that I've worked with when I've offered to kind of stick my head above the parapet to protect the investigator a bit from having to plead and beg. And finally, as chair, it's not your trial. One can get very involved in the conduct and analysis. One can have very strong views about what words should be used in explaining them or contextualizing the results of the study. One can certainly voice one's opinion, but you are not the principal investigator, and it is the views of the principal investigator and the co-investigators that will be expressed in the paper. So that's the time to kind of shut up and let the principal investigator say what he or she wishes to say in the words that they wish to choose. I think that's all I have to say. Thank you.
I think we'll move now to questions. So I'm just going to have a look at some that have come up in the chat. So there's one here that says, reflecting on Mark's comment already, the importance of the relational aspects and building lunch, etc. Any suggestions on how we could do that under the current restrictions, which may also extend to low carbon trials and so on post-COVID?
Shall I start? I think it's really difficult. And I was commenting it. So with Upstream, I used to take the kind of day off from work, which is very nice, get the train down, read the papers on the train, and then spend the afternoon with the team, usually with lunch thrown in, and have a little walk around Bristol. It was a kind of very nice day. But it gave me plenty of time to think about the study and actually meet everybody in person, which was fantastic. That's really difficult now. A meeting will be put in between other teams or Zoom meetings, and so one doesn't have the luxury of that time or that social interaction. So I think it's very, very challenging, particularly if you don't know the team and have got to make relationships from the start. I don't have any easy solutions for this. We are getting better at interacting virtually and forming confidences and trusting each other just based on virtual interaction. But I'd be very, very keen to hear what others have to say about creating some glue, some social glue without formal face-to-face interaction.
Deborah, Peter?
Yeah, I don't have any great insights. I mean, I think it does raise the issue that you need to put some work in to do that. Now we've gone virtual. So I think that first meeting where you meet all the team and Mark's just said is so important. So I think you have to think about how you're going to replicate that, because it does come down to personalities, and you need that relationship to make the thing function well. So yeah, some thought again about preparing for the role.
So I think it raises the more general question about online working. I have to say that over the years, what were always face-to-face meetings for DMCs and TSCs at one point had largely gone over to those wretched teleconferences that I don't miss. over time anyway. And my feeling is that if you're in a mixed mode, and I know we're not really in a mixed mode at the moment, then what you should do is when you have a face-to-face meeting, you should do the social stuff and bond. And then if you've then got, especially if they're fairly regular, stick to the agenda and they work well, but you do need that other time. So I guess in this world, the first meeting needs to allow time for people to talk, to get to know each other, because as others have said, you're often, if you're the chair or even a member of a group, you won't necessarily know all of the others, and it's even more dangerous if you know one or two well but not some of the others. And so that kind of understanding where people are coming from, what their expertise is, what their experience of TSCs is important. And that comes back to the much more general question of chairing, of you have to make time to chair. I mean, it took me a long while to learn that. And if in London I often walk to meetings anyway, I put block time in my diary for if I've got a 2-hour meeting, I will block out 2 hours a day or two before to do the preparation for the chairing. That's as much part of the job as the face-to-face or the Zoom meeting. So,
okay. So I think, Peter, you mentioned spade work, and that being a TSC chair or even a member on a TSC is one of those kind of academic paybacks that you do. But someone's posted a question relating to also whether or not there should be some kind of payback in terms of authorship or for reimbursement for time.
So I'm not of that opinion. I do think that there's so much of this that makes up academia. It's the glue that keeps the community together. So I'm quite happy doing that. I don't know if my employer is happy me doing that for that amount of time. But I think authorship, it gets complicated. Payment, it gets complicated. I think it's about reciprocity. And that's what it's based on, because you're going to have to go out to the community and find somebody. You said yourself, Carol, about how difficult it is with the rules. So I don't think we should try and incentivize it too much. I'd come back to some of the things that other people have said. It's actually a lot of fun. You learn loads. It's not just work. When I described it as spade work, it's slightly unfortunate because it does underestimate. I think that actually it's a learning experience for all of us. So I'd be wary of going down that line, but it does need recognition, and employees, etc., need to know that this is really important. It's keeping their trials safe. So I think that there's recognition without going down the authorship line.
Yeah, well, I go more strongly than that. I think it is inappropriate to be an author because you're independent. And if you think you've got a New England Journal paper writing on this, then, or an important paper, then you start to become part of the trial team. So you should be acknowledged on the paper, but you should not be an author. Now, I think on that, and I've wrote something Matt Sides has done more than I have, I think if we were to move to a world where we had something a bit like the film database of what people have done, then you could list TSC roles in that, because it's nice to do it, but it shouldn't be authorship. And on payment, you should get expenses met. So if you do go for a face-to-face meeting, they should be meeting your train fare and a hotel if it's needed. For publicly funded trials, I don't think reimbursement is appropriate. I think there's a slightly separate issue if we've got patient representatives. Often they reimburse for things that other people aren't. I think one of the more interesting ones, I'd be interested in other people's view, is if you're chairing something for industry, there's the question of should they be recompensing? And the question is, should they be recompensing you? Should they be recompensing your institution? So there's a tension there between keeping independence and yet not doing a whole lot of stuff for free for people who are going to be making a big profit out of it. I'm parodying because I know it's not quite as straightforward as that. So I would throw that one back in as a question.
Okay.
There are. It is a measure of esteem to be a chair. To be asked means that somebody's put trust in you, and if you are associated with delivering a successful trial, there is some kind of halo effect. And I think when you're going for promotion, NIHR professorships and senior investigator awards, etc., having steered a complex trial through, I think is an important measure of your ability to manage complexity and a team over time. So I think it is noted, and it is a useful thing to put down when you are seeking to go for an NIHR whatever senior investigator award or indeed anything else. So it is acknowledged, I would argue.
So do put it on your CV. If you're doing some statisticians and other trialists are very good at doing these, and others sort of regard it as sort of slightly peripheral, but absolutely keep these things on your CV, because it is evident, particularly at a certain stage of promotion, it's really good evidence that someone regards you as senior enough to be independent. And it certainly, when I'm looking at people for promotion, it's for trialist at a certain stage, you're almost thinking, well, if they're not doing some of this kind of stuff, why not?
Okay, so one of the things that we're hoping will stem from this course is that we will increase the number of people who are willing to consider taking on the role of a TSC chair. And so one of the question in two parts. One is, should we have a TSC experts panel that TSC chairs can go to confidentially for advice that they might find themselves in a tricky situation, which then might make people feel more supported in their role? And the second part to that is around mentorship. Are we doing enough to mentor people in their roles as TSC chairs?
So if I can answer the mentor one, I mean, I think we don't do enough of this sort of mentorship across the academic piece, if I'm honest. And I don't think I've had any training for this, so it's great to see what's coming out of this the work that you're doing. But yeah, I think it's a role for mentors. I mean, you should be inviting people along, junior colleagues, to see how it's done. So yeah, probably more the mentorship for me. I think that's probably more important, and we should see that as a key role. Why haven't you got a junior colleague if you're on watching what's happening, seeing what's being developed? So out of the two, I think that would be probably better. The expert group, I think that could get complicated given the politics, but interested in the views of others.
Yes, I mean, I think the idea that you probably shouldn't be chairing a TSC until you've sat on a number of TSCs or seen them from the other side. So the two things you need is experience of what a TSC is about, and then experience of chairing, which is something you can do training courses for. Yeah, I'm not sure an expert panel. I mean, I think the idea of a network that you can, there are people I would talk to in confidence if I thought I did have a tricky issue. I get emailed by people, I mean, on this and other things from time to time saying, look, we've got a difficult issue. I'm not sure we need a dedicated panel, because the person you would go to on one trial might be quite different to one on the other. But again, others may feel differently.
No, I agree. I mean, I suppose one good thing about the virtual approach is that it is easier for other people to attend. So, one's research fellow or somebody working in your unit who wants to get a flavour of what a TSC is like in terms of dynamics, etc. It's much easier than taking a day off, travelling across the country, and maybe staying the night, and the budget for that would be hard to secure. So there are some good elements of doing things online, which means that more people can participate.
So someone's posted a comment that went back to a point that you made earlier, Deborah, which was around put it on your CV and it should get recognised. So somebody's asked, do universities appreciate their staff for sitting on external TSCs? Do you think that's a universal perspective?
I mean, I think the more general point is that universities, doing external things at some point is a mark of external recognition. In teaching, the analogue, I think, is you do PhD examining, you're external examiner for courses, and it's a huge amount of work, but it's also evidence that you're taken seriously. And if some universities really resent you doing that kind of thing, then you need a bit of a debate about you're in the right place. Obviously, if you're doing masses of that kind of thing and you're not then doing your day job, that may not be fair on colleagues. But I think these markers of external esteem are usually part of every university's sort of way of looking at people. But yeah,
I agree. There are explicit promotions criteria now: external engagement, facilitating, enabling. I'm sorry, my printer's just off next door. But I think so. In promotions, they're essential attributes in most university systems. Whether or not it. So for clinical academics, it's sometimes problematic if you have to take a clinic day off. The NHS increasingly are less and less tolerant of that. And if you're a GP that does it, you will need your session covered financially so that a locum can see those patients. So there's kind of there may be some issues with clinical time, because the NHS are getting much harder to swap clinical time for academic time these days.
Okay. So in a couple of the talks, there was a mention about the importance of the terms of reference and understanding the remit of the TSC committee. So in terms of what you've seen over the years, what have been the biggest stumbling blocks, or the points that you kind of would look for within your terms of reference or remit?
I mean, for me, it's just the sheer heterogeneity. And I think if you've largely been working, especially if it's in a well-run trials unit that's got a particular way of running TSCs, you may think that that's the only way of doing it, and it become quite a nasty shock when you realise that other people are making assumptions. So I think the point I'm making is it's worth explicit conversations about what the role is, what we're working under, and that's where a charter or terms of reference or whatever they are help to flush those out. And industry ones are often done very differently. US ones are done differently to UK ones. So don't assume.
Have you ever had to say no because you couldn't get on board with the terms of reference?
No, the example I gave in my talk was where I realised that the trial was set up on one model that I could see where it had come from in that trial, but it wasn't this was a different study. So, but we talked about it. We talked about why, and actually we flushed out some important things and separated them. So it wasn't quite saying no.
Mm-hmm.
I mean, it's usually the discussions at the beginning that set the tone for everything else.
Okay.
I'm more worried about the ones where there isn't that discussion and you're asked to do it, hear nothing for 9 months, and then you get a Zoom invite in your diary and you barely ask when it is. That's when my red bells start going. When it's all written down and you can talk, it's a much sounder basis.
Okay. Mark, Peter, anything to add?
Yeah, I've not noticed anything fundamental. Again, I'll come back to the point that I think some of the issues where it gets complicated are so specific to the trial and the way it's set up. It's very difficult for generic terms of reference to cover that. But I'd go back to Deborah's point. I suppose it's about preparing for the meetings where those discussions are going to be had, so that you're not having that difficult discussion on that day, that you've clarified those issues. So if you're not sure going in, you need to have those conversations before with the funder, sponsor and PI to make sure that meeting, everyone knows what the scope and the remit of that meeting is. But I've not noticed major issues with those written documents.
I think the process of setting up terms of reference is as important as the document, as what's in it. So because it forces you to have discussions and clarify roles so that everybody knows what their kind of duties are. And also terms of reference, you can't anticipate everything and you can't foresee everything. And it may be necessary to change those terms of reference or to modify them if you come across something that you didn't anticipate, like COVID, for instance, and all terms of reference had to change because of COVID. So I think retaining some flexibility in the terms and then re-agreeing them with everybody if the situation changes dramatically is also a kind of sensible thing to do. So I think the process of creating them is probably the most important bit.
So the final question is around length of tenure on a TSC. So when does the TSC stop?
God, that's a really interesting question. I mean, my general understanding is that if it's a single trial TSC, it lasts for the duration of the trial. So again, you need to know at the beginning whether that's a 6-month trial or whether it's a 20-year trial. And obviously, when you've got very long ones, you do sometimes get rotation of members. But I think the question of when the TSC responsibility stops is fascinating, because if sometimes you see related issues such as making the data available. And I've seen people write down, well, that's the TSC will do that. Well, if you're talking about requests for data for a trial that took place 5 years ago, I wouldn't see that as part of my remit. So for me, broadly speaking, it would stop at the kind of the key publication. But if there's extended follow-up, then you should know that and negotiate it. But things that happen 10 years later, I wouldn't regard as part of my role, but maybe I'm just a meanie.
I tend to agree, but Peter and Mark?
No, I agree. I suppose mine would be slightly forward from that. It's that presentation of the results where you have the results, there's a discussion, you give your view as a TSC. Post then, I think that's for the team. They got to take it forward to publication. But as Deborah points out, there's always these issues about if they do a long-term follow-up and so on. So again, it's very trial specific. But I think you do need to know when to call it a close, when you've actually got no more useful work to do. There's nothing actually more you can do with this. So, you know, they're off on their own devices then. So I think that's when I'd call it a close. I think.
Yeah, I just kind of raised the issue of data sharing. So the trialists, everybody wants to keep hold of their data, and you know, the TSC chair has a role, I think, in terms of open science to make sure that that data becomes available to other researchers eventually. And it's often that, because if the chair doesn't do it, it won't happen, because there's always one more analysis that everybody wants to do before it, and making something, you know, findable and accessible is quite a bit of work. And that's kind of interesting dynamic that I'm currently involved in, you know, from both ends. So being pushed to do it and also encouraging others to do it, and that's difficult. You've got no, you can't force it to happen, but at least you can impose a little bit of direction.
That's great. Okay, so a huge thank you to Peter, Mark and Deborah.
Hi, my name's Alan Montgomery and I'm Director of the Nottingham Clinical Trials Unit, and my talk today is about interactions between trial steering committees and clinical trials units. So the outline of my talk is I'm just going to say something about the roles and the experiences that people bring to a TSC. I'm then going to talk about what exactly is a clinical trials unit and the roles that a CTU might play in delivering research, and then just some other considerations about interactions between TSCs and CTUs. So members of trial steering committees will very often have experience of more than one role. And because of this, it means that they're able to see both sides of the fence. So for example, non-independent members of the research teams, the chief investigator or co-investigators, whether they be clinical or methodological, will very likely also have experience of sitting on the other side of the fence as independent members on other people's trial steering committees. So either as the chair, as a member, or possibly also on data monitoring committees, so another oversight committee. And some of these will also have experience of being on funding committees, either as chair or as members. So round the table on the trial steering committee for any given trial, you'll have people who will have experience of sitting in other people's seats on other committees. And that's useful to know, because I think recognising the skills and the experience that people bring, and you as a potential TSC chair, you will also have that experience as for example, as a chief investigator or as a co-investigator. So being able to understand other people's points of view and being able to know what it feels like to sit in their shoes. What is a CTU? Well, it's defined here as infrastructure for delivering multi-centre clinical trials. But really it's about people. It's about the people within a CTU, multidisciplinary teams, people who come from different backgrounds with different skills, working together to design and deliver complex projects. And what does a CTU do? Well, likely that they could be involved in all of these different things, all the way through from taking an idea and working to develop that into an answerable research question, all the way through to publishing results and archiving data and sharing data, and everything in between. So what kind of people do you need then in a CTU to be able to do that sort of work? Well, there's a statistician, patient and public members, doctors, trial managers, research nurses, administrators, health economists, data managers, database programmers, and QA managers. So a large number of different roles, people with different skills, who are all essential members of the team to be able to design and deliver these large, complex trials. So what happens when we lift the lid on the trial team? So we've listed everyone there that needs to be present within a trial team in order to be able to design and deliver that research, but would they necessarily all need to be part of the same CTU? So when you look under the lid of the trial team, does it look like this? It's neat, it's tidy, it's well aligned, there is a clear tool for every job, it's easy to find, and everyone knows exactly what they're doing? Or does it look a bit more like this, where everything that you need to do the job probably is there? There might be more than one tool that could do the job, so there might be some duplication. It might be quite difficult to find the tool that you need to do the job, so not being exactly clear about who is doing what. So just knowing what's under the lid of the trial team can be helpful, particularly when a lot of these roles that you might expect to find within a CTU. So in this slide here, we can see that all of these functions in the orange box are all within the same CTU, they're within the same organisation. Now that might also be the same organisation as the chief investigator and the sponsor. So for example, here at the University of Nottingham, we'd have Nottingham CTU with a CI who is also at the University of Nottingham, and that organisation would also be the sponsor. There might be some co-investigators who are also here in Nottingham, but likely there'll be co-Is from other organisations around the country. But the functions of the CTU, there's a clear alignment there that they're all within the same CTU. But it might also look a bit like this, where the CTU takes a more limited role. So all the things that the trial team needs to deliver the research are there, but they're not all necessarily within the CTU. So for example, the CTU may only be taking the lead on the statistics and the health economics aspect of the work, with the other functions happening elsewhere. Or it could be that the CTU is taking the lead on trial management, QA, and data management, with other aspects happening elsewhere. So I think it's worth saying that CTUs can and do have the capability to do all of these things, but they don't necessarily always do them on every single trial. And as a TSC chair, that's worth you knowing, because if there are problems in the study, I think just being able to pinpoint exactly where those problems are is helpful. I think it's certainly possible that a trial team where these functions are not all within a single CTU, those trials of course can be well run and deliver exactly what they were intended to deliver. But it's also possible that that things can go wrong, where there is some slippage, there's a hold up in one area that then has a knock-on effect elsewhere that is just more difficult to manage when these functions are being conducted across different organisations potentially. So just some other considerations then in interactions between CTUs and trial steering committees. It's no surprise to say that some trials struggle, and CTUs have a lot of experience in managing studies that deliver well, deliver ahead of time, but also studies that struggle. And I think that collectively CTU members of a team are likely to have been involved in many more studies than, for example, the chief investigator has, just by the nature of the work that we do. We get involved in lots of studies. And I think that experience is helpful in being able to assess the likelihood of success, the likelihood of the trial being able to answer the research question. And the threshold for stopping may be different within different members of the same trial team. I think that the CI typically may want to ensure that the study is given absolutely every chance and keep going because they desperately want the trial to succeed and answer the question. Whereas the CTU may recognise the point when the study is just too difficult. It's not going to be able to answer the research question. SOPs are also just worth considering. Is the study and the CTU working to the sponsors' set of SOPs, or the CTU have their own complete suite of SOPs, or is it some sort of hybrid model? So again, if there are aspects of the trial where there are difficulties, worth just knowing whose SOPs are being used to govern the study, and that includes governing the actual oversight committee itself. So does the CTU have a SOP for managing the trial steering committee? So for example, the timetable for sending out papers before meetings, minutes afterwards, the contents of the report, and so on. So in summary, there's usually a lot of experience around the table in a trial steering committee that people have had sitting in different roles, and that can be incredibly helpful to recognise that. CTUs can perform all the functions required to deliver a study, but they don't always do so for every single study. So it's worth just knowing the alignment of these functions within the trial team. Are they all within the same CTU, or are there different organisations that are contributing the different roles to the trial team? And linked to this also, whose SOPs are governing the conduct of the study. And lastly, I think everyone wants to give the trial absolutely every chance it can to succeed, but there does sometimes come a time when we have to recognise that there's a low likelihood of producing an answer. And it's possible that within a trial team there may be different views on that, or different thresholds, because of the different levels of experience that the CTU members may have had in recognising when that point has been reached for a given trial. So that's all I've got to say. Thank you very much.
Hi, I'm Joan Cook, and I work for the Patient and Public Involvement team at the NIHR Evaluation, Trials and Studies Coordinating Centre, otherwise known as NetCC. I've worked at NetCC for nearly 12 years, and most of my time within the organisation has been split between working in patient and public involvement and monitoring a variety of NIHR-funded projects from initial funding decisions to the point where they submit their draft final reports. From 2015 through 2020, I was the point of contact between the NIHR and the individual project teams within my portfolio, of which there were about 30 at any given time. Essentially, I was a link between funded investigators, sponsors, steering committees, the NIHR, co-funders, and the Department of Health and Social Care, who want to ensure that NIHR-funded projects comply with the terms of their funding contracts. During this time, I was responsible for ensuring compliance with the legal requirements of good clinical practice and adherence to the required national public research management and approval frameworks, critically appraising project performance against agreed targets, and ensuring appropriate trial oversight committees, including trial steering committees and study steering committees, were established, and that both members and chairs were appointed. In October, I moved from the monitoring team and returned to the PPI team, where I spent my first 5 years at NetCC. My role now is to undertake projects to support and improve patient and public involvement across a variety of activities undertaken across NetCC and the wider NIHR. In preparation for this presentation, I recently approached a couple of public TSC members from funded projects that had been within my monitoring portfolio. I asked them to very briefly tell me what they wished they had known when they first went to their first TSC meeting, and here are a couple of their comments. I also asked them to reflect on their experience as a public TSC member and think of what might help other public TSC members in the future. I received comments such as, "I'm there for the difference I can make," "It's vital that the patient voice is heard," and "Familiarity makes getting one's head around a project easier." Today I'm going to talk about the recruitment and involvement of public members on trial steering committees and study steering committees, but for simplicity I will refer to them simply as steering committees from this point on. This will include NIHR requirements of steering committee public membership, the work that has gone into our evaluation and development of co-produced guidance that will shortly be published relating to PPI on steering committees, the key areas covered by this new guidance, and how to find the new guidance on the recruitment and involvement of public members on steering committees. All NIHR-funded primary research projects are required to establish a steering committee. The role of a steering committee is to ensure that the project that it is overseeing is conducted to the rigorous standards set out in the Department of Health's Research Governance Framework for Health and Social Care and the Guidelines for Good Clinical Practice. and to provide overall supervision for its project on behalf of the project funder and project sponsor. When we refer to the project sponsor, we mean the individual, the organization, or the group of individuals or organizations responsible for confirming that there are proper arrangements in place to initiate, manage, monitor, and finance a study. The steering committee should monitor the progress and conduct of the study that it is overseeing and advise on scientific credibility. The steering committee will consider and act upon the recommendations of the Data Monitoring and Ethics Committee. And, ultimately, it carries the responsibility for deciding whether a trial needs to be stopped on the grounds of safety or efficacy. All steering committees should include at least one individual who is able to contribute a patient and or wider public perspective. Public members of steering committees should ideally have either personal lived experience of the subject being researched or relevant experience that will add value to the conduct of the study. This may include experience of a particular condition or service as a patient or a carer, or as a member of the public who is affected by the issues being researched. In 2015 and 16, the NetCC PPI team undertook an evaluation to understand the role, impact, and the value of the public contributor on steering committees from the perspective of public contributors and steering committee chairs. The intention was that this knowledge might then be utilized to inform future guidance and possibly to develop support resources. We aim to identify what worked well for steering committees and public contributors and also what didn't. 25 projects from the NIHR EMI and HTA programs were analysed. 9 public members and 7 chairs of steering committees took part in semi-structured telephone interviews, and the interviews were partially transcribed and a qualitative thematic analysis was undertaken. The public members had various backgrounds. 7 had lived experience of the topic under study as a patient or carer. 2 were charity representatives with no lived experience of the conditions. 3 had health professional or service management backgrounds, and 2 had no previous experience of research involvement. So, some key findings. Public members contributed to many practical aspects of the studies, including recruitment, dissemination strategy, and document review, and they provided a different perspective, or an outside and real-world perspective that can prevent tunnel vision. Public perspective ensures the research that is carried out is relevant and needed. There was also a view that NIHR research is funded by public money, so the public has a right, even a duty, to ensure that it's spent wisely. One public contributor said, having a public voice prevents the researchers from being carried away in the academic bubble of research. Some barriers to effective public member contribution were also identified. Recruitment of public members to steering committees was often unsystematic and opportunistic. There could be an over-reliance on a small number of experienced public contributors, and there was no formal role description for public members on steering committees. No training was offered, partly because many public steering committee members were often perceived as experienced. When asked what facilitated an effective public contribution, chair and public members suggested the following: giving time to explain the study, roles and responsibilities, helping the public member to build a relationship with the group, a chair with a commitment to public involvement, good chairing where a public member is included, involved and encouraged, and therefore creating a conducive environment, having more than one public steering committee member for breadth of views and peer support. A successful contribution is dependent upon the steering committee's commitment to public involvement, interpersonal chairing skills, and effective methods of communication. Scope for the development of a role description and good practice guidelines for public members on steering committees. As a result of the evaluation undertaken by the NetCC PPI team, a series of projects ensued, resulting in the co-production of guidelines for the recruitment and involvement of public members on steering committees for NIHR-funded projects. The guidelines that have been developed are aimed at research teams, public contributors, and steering committee members and chairs. Throughout the guidance development, various events and methods were used throughout the guidance development to involve public contributors, researchers, trialists, and NIHR staff, including research design services, research programs, PPI leads, and involve which is now the NIHR Centre for Engagement and Dissemination, or CED. So, what do the guidelines provide? They provide a definition of research oversight groups, including steering committees, a description of the public member role and expectations, an outline of good practice for recruitment and involvement of public members on steering committees, including public member involvement at meetings, the expectation that public members are equal to other members of the steering committees, resources relating to payment, plain English, PPI learning and development, a role description for public steering committee members, an outline of what steering committees do, a person specification, and terms and conditions of membership on steering committees. I'm now going to take a brief look at some key areas covered by the guidance in a little more detail. First is the role of the public steering committee member. They are involved in all aspects of the work of the steering committee they join. Public members join on equal footing with the clinical and academic members. They should bring to the discussion their experience of a particular condition or service as a patient or carer, or members of the public who is affected by the issues being researched. Through their lived experience, they may contribute by considering the perspective of a potential study participant, assisting with recruitment and retention plans, provide a fresh critical friend perspective on the feasibility of study design, offer advice on the planned PPI in the study, including adherence to protocol and milestones. I'm going to now discuss good practice for committee meeting involvement in terms of public involvement, which builds on the feedback received through the earlier evaluation. The research team, and particularly the steering committee chair, have a duty of care to the public member. Reflecting on the feedback from the evaluation carried out in 2015, when asked what facilitated an effective public contribution, responses included a chair with a commitment to public involvement, and good chairing where a public member is included, involved and encouraged, and therefore creating a conducive environment. Of course, the following recommendations should be tailored to the support needs and experience of each individual. But prior to the first meeting, the chair and the project team should ensure the public member is clear on their role and the role of the steering committee, and that the access and support needs of the public member are known and accounted for, and that a named contact is provided to manage expectations. Agree any rewards or payments and ensure that guidance documents are shared and the impact payments can have on benefits is understood. Discuss acceptable methods of communication and meeting practicalities. That public members are offered an explanation of the technology used for virtual meetings, are directed to learning and development resources, and possibly offered a mentor. A few important things to remember about the first few meetings. The first few meetings are vital to relationship building. Try to make the first meeting face-to-face so that members have a chance to meet each other. This can be costly, but if budgeted for, it will facilitate effective future working relationships. Prior to the first meeting, take time to get to know your public member by an informal pre-meet. Building a personal relationship with the public member will increase their confidence and hence ability to contribute. Make sure the public member is well briefed on the role and membership of the steering committee and its relationship with other study groups. If necessary, give a plain English explanation of each member's professional role. This might actually benefit all members anyways. Things to consider during meetings. Meetings may be face-to-face or via tele or video conferencing, so ensure that the public member is supported to contribute. Good sharing skills which facilitate participation are key. Invite the public member to voice their opinion or raise questions. Recognize when members look confused and respond. Notice body language. Allow time for all to speak. And although public members are equal participants throughout the meeting, the committee may wish to consider having a specific PPI item on the agenda to facilitate participation. Check that your public member understands the issues raised. Explain complex issues in technical language. Now, all this takes time, but crucially, it will support an individual to make a useful contribution to the steering committee and hence the study. After meetings, provide feedback to public members at regular intervals and when requested. Guidance on the value and content of useful feedback is provided in the guidelines. Allow public members time to reflect on the meeting and ask if they have any questions. If the public member wishes to raise any issues, this should be directed to the chair of the steering committee. The NIHR Research Governance Guidelines are available on the NIHR website. And the new guidelines that are being finalised after more than 6 years of development will soon be available on the NIHR website at the address on the slide. Thank you.
Great. So thanks to Jen for putting together that report. I think that's really helpful. It really sets out that there are challenges for everybody in serving on TSCs, and I hope you're feeling that today. And what you're seeing across the presentations, the discussions, is many areas of agreement and simplicity in knowing that we're taking the right approach, but also many areas potentially of disagreement or uncertainty about how people approach this. And I think that's quite useful to know. I mean, maybe just before we launch into the questions to Jen and Malcolm, maybe some of you have had a chance to just look at the Padlet page about how the discussion had gone for other groups before lunchtime. In that breakout, and Malcolm and I were in the same group, and conscious that we'd very deliberately given you a slightly crappy report, because that's not totally untypical that trial teams would give you less context and less information than you'll want to see. And I think it's even more difficult. I mean, it's difficult for everybody when you present information like that, right? But even more difficult for PPI members within that. There's a couple of other things we'll come back to within the points that came out of breakout session 1, but I'd like to welcome Malcolm and Jen to this Q&A session, and I'll kick off by asking you then, let's have that training in mind. Whose responsibility do you think it is to make sure that a PPI member of a TSC is feeling comfortable? Is that for the trial, for the TSC chair to do? Is it for the trial manager to do? Is it somebody else? Should it be done at the meeting or before the meeting? How do we get the most out of or how do we ensure that PPI members feel like they're giving the most to a meeting? Malcolm, do you want to kick off with that one?
Well, I think from my experience on the 2 TSC I'm still involved, which are urology ones. So there's a subject area which I know something about. I came into the upstream one partway through, actually, because the original representative had withdrawn for some reason. I remember the first meeting I went to, which is in London, where and I was made quite welcome by the chair, and I think if you like, it's a face-to-face meeting, obviously in those days, back in 2016, and it was a good way of settling down, and we had lunch and all that sort of thing. I think going forward in the current environment with virtual meetings, that interaction may be more difficult. But I think recognizing that, I think for new setups, I think there probably does need to be some sort of allocation of time given to more than a sort of couple of minutes, if you like. I'm not saying that was too short actually, but just sort of briefing a TSC member about the trial, because one gets these things like the protocols and that sort of thing, and but it's a lot of information to take on board from a 40-page document, whatever, and much of that has been discussed in smaller meetings. So I would say that would be quite key actually, to spend some time at the start with a new PPI member on the TSC.
Yeah, okay, so particularly at the start, that's very helpful, Malcolm. What do you think between meetings, Jen? Whose responsibility is it to make sure that the TSC members, particularly the PPI members, feel up to speed?
I think it's joint responsibility, really, to be honest. I think that the chair of the TSC has the responsibility, but equally, I think it could come from the project team as well. I think there's room for trial managers, the CI, to also ensure that the member or members indeed are aware of the terminology that's used, feel supported, and are aware of references and support documents that are available. So the new guidance that I was referring to does have a number of links embedded within the guidance of different training documents as well. So I think it's sort of a combined approach, but being able to direct them to those documents for some further support would also be key.
Okay, that's really helpful. Thank you. And where best should we, have PPI? Certainly, I've been involved in trials that have had PPI members for the better part of 20 years, and on the trial management group, increasingly so I see it on the trial steering committee, and I've no experience of it on data monitoring committees. Where best should we be having PPI members? Should it be on all of those committees, or should it be limited? Jen, do you want to take that first?
Well, from NIHR's perspective, we try to have public involvement all the way through, from when the research topic is being developed all the way through. We don't insist that there are members of the public on the DMEC, whereas we do require 1 to 2 public members on the TSC. I think there's a number of reasons behind the decision not to require a public member on the DMEC. I mean, from an ethical perspective, there's definitely scope to have a public perspective, but I think that also gets picked up in various other areas of scrutiny throughout the decision-making processes. So there's, if you've got a public member on the trial management, on the TSC, there's never been a view that it's required on the DMEC as well. But yes, we do try to have it all the way through, from the start to finish, right through to dissemination as well.
Okay, and what do you think, Malcolm?
I think as regards to the other committees, I do get minutes or do see minutes for some of them. I don't necessarily feel that I would personally need to go beyond my involvement in the TSC as such, although it might be interesting to perhaps attend some of those other meetings from time to time. But one, going towards the second TSC topic I'm still involved with, actually, for that particular one, which is another urology trial. I was been involved with that from the start, actually, if you like, from more or less the, I wouldn't say the planning phase, and the ideas have come from obviously within the urology department, but from the aspect of, drawing up a patient booklet, which was quite an interesting part of it. And that was, I don't know whether you call that a formal part of the TSA activity, but it all woven into the project. And I think that was good to be involved, right at the start of the trial, at the planning of it, really. I'd see that as, as important as maybe getting involved in other committees, if you like, where, maybe just other aspects of the data might be discussed which are not appropriate for a member of the public to be involved with, perhaps.
Okay, thank you. There's a question in the Padlet about the blurring of roles for PPI members. Is it clear how the delineation between the role of the PPI member on a TMG, on a TSC, on an IDMC? Surely it should be as delineated as it is for a statistician sitting on any of these. But do you think PPI folk see it that way? Malcolm, do you want to go first?
Well, I find it difficult to talk beyond my experience on the trial steering committee as such, and without having had the opportunity of, maybe it's not one I would want to take up actually, to be involved with the other committees. I'm not absolutely sure I really can comment on that in any great detail, to be honest.
That's fine, Malcolm. Jen, did you want to pick up on that?
Well, I'm hoping perhaps that the new guidance will actually clearly define the role of the public TSC member, and I think if that's the role that they're being appointed to, it would be appropriate to stick within the realms of that role description, and if there's a need to have a member of the public on trial management, perhaps it shouldn't be the same public member. Maybe it should be an alternative member.
Certainly, if they're going to be independent, then I guess it would need to be. I haven't seen the experience where one of the non-independent members of the TSC was the PPI person from the TMG. I mean, I guess that is possible, but I've not experienced that at all.
Having gone through nominations, I've not come across that myself either. That's not one that's come to my attention either.
It's a little bit of guidance that people are putting into the chat, saying sometimes when you get emails, it's directing the PPI person. Actually, it's helpful for anybody to say, would you mind concentrating on section X and just drawing it to people's attention? That can be good. And a couple of people saying that they like the pre-meeting for PPI folk just to make sure they feel more comfortable. Yeah, certainly I agree from my own experience that it's important that PPI members feel up to speed. I'm sitting on one pretty big trial at the moment where there are 2 PPI members, a statistician, that's me, 2 clinicians. One of the clinicians is chairing and is a phenomenally experienced, brilliant chair, doing a great job at trying to get the TSC folk, the PPI folk to engage, but they're really not. As much as I might have expected, and it's a difficult trial. I mean, it's full on as a trial, and I wonder, is there a route for people to say, actually, this isn't for me, get somebody else to do this? Or is there a sense that people need to stay on this committee? So, it's about the intensity of that trial. I'm not saying these people, I'm not sure they feel this. Let's stay hypothetical. But is there a route for people to back down or to feel like they can swap out? Jen, what do you think?
I have come across this before on other trials. One was an incredibly long trial. Another one was a complex trial. And I think I've had one as well where the member of the public didn't have much actual personal experience of the topic area as well. And it is okay for them to step down. There are means to nominate someone new into the role if it's not the right one. But I think it's interesting and important to find out perhaps why they're not engaging as much as they could. Perhaps they don't feel able to speak in the meetings, or they're not directed to the right areas where they can make the most impact. So I think possibly having a discussion to find out how they might be more supported to contribute might be a first step that could be quite helpful.
I think that's a good idea. And somebody's put into the chat that it's the same. If one of the statisticians or the clinicians wasn't contributing in the way they should, then there would be a conversation. It just feels, I feel, if there's equity of membership,
yes,
then there's equity of contribution, and we need to make sure that everybody feels like they can contribute in a good way, don't we? So we talk about, you wanted people who are experienced. We're all patients at some point or another. Many people will end up with something. May then be invited to sit, a researcher, a clinician, a statistician, an operations person, who's had a condition in question may end up being invited to be on a TSC. Can they serve that patient and public representative role as well, or must we always have somebody who's more research distant in order to take on that role? What's our thoughts on this from both of you?
I think for my experience of the TSCs I've been involved with, I found it very useful that I've had an understanding of the subject area in many regards, actually, simply in many respects, just from the things like the acronyms and what are we seeking to achieve with this particular groups of patients. And one particular aspect I would raise, though, which has been very pertinent to the TRIUMPH study in particular, which I'm still involved with, is I've been really the sole PPI person on the committee recently, at least, actually. But we've had in addition to that, patient advisory groups, one of which I chaired not so long, well, some months ago now it was. So that's enabled other patients, if you like, to be drawn into the study, and that's formed quite a key part of that particular one. And I think that is I'd say that would be quite an important part of the TSC PPI aspect of, if you like. I mean, you could have sort of maybe several PPI people, but at some point it's probably going to get a bit counterproductive, and or may end up with people talking about their personal experiences, which can be a problem actually sometimes in this sort of thing.
Sure, absolutely, okay. So someone
they
said
have an opportunity to do that in a patient advisory group.
Okay, patient advisory group. So that's good. Somebody's put it. No, go on, Jen. Pick up on this.
I was going to add. I have one project that was in my portfolio, and one of the patient representatives on the TSC worked down the corridor from the CI and wasn't that independent at all, but they had come to the role in an advisory capacity, and they knew too much about research. They knew too much about how clinical trials worked to really be able to provide a patient perspective. Now, they weren't actually a formal member on the TSC, but they'd be asked opinions based on the condition, and it actually became quite problematic because they understood too much. And so whilst they understood the condition itself, they also understood how research works too much. And so there was a presumed sort of feeling that patients understand what it's like to be recruited, and that there's a vulnerability sometimes that I think patients can bring through their distance from the research team as well. So
yeah, I agree entirely, and I think while it may be useful to have a researcher that intimately understands a condition, having that distance is really helpful as well.
Yeah, I think
okay, so,
just comments on that comment from Jen. It's something I can actually buy into, that because as I say, in the ones I've been involved in, I've known quite a bit about the subject, and I've sometimes felt, well, maybe I know a little bit too much, if you like. And you know, there's a third trial, set of trials which I'm involved in, which I won't go into, where I don't know anything about it, and that's some work over at Oxford. And in some respects, it's sort of easier to do that than something I know something about. It may sound a strange thing to say that, but it's how it appears to me sometimes.
Okay. Now, I'm very conscious we're keeping this section short because everyone feels a little bit sluggish after lunch and Zoom is difficult. So we're already 2 minutes over time to let you get to your break. But I wanted to pick out a couple of things that are in the chat. One about people feeling that PPI knowledge some knowledge is useful, and I think it's important everybody feels up to speed. One about engagement and making sure people feel engaged. One about PPI folk being able to talk to each other, some kind of community support, maybe some kind of group that we've got to do that in a way that makes sure that information isn't being shared that shouldn't be shared as well. So careful route about how we do that, I think is really important. And somebody's asked whether PPI members could the PPI member ever be the chair of the trial steering committee? Let's take that as our final question. Malcolm, Jen, what do you think?
I personally, I think I'd find that difficult. I think one would need, personally, I think I would need a lot more experience of either from a clinical point of view or from that aspect of management, if you like.
That's fair enough. Thank you, Malcolm. Jen, what do you think? PPI ever chair in the TSC?
It's an interesting one. I don't know. I wouldn't like to say.
Okay.
It is tricky.
That's fair enough. Look, so the first funding committee I ever sat on for Cancer Research UK 15 years ago, whatever it is, some hideous time, there was a PPI member chairing that committee, and he was amazing. But proper full-on organisational skills that were above and beyond nearly anybody I've ever met who's a researcher or otherwise, just general ability, and was super well prepped. So it's tough for anybody to do. The role of TSC chair is tough for everybody. I think you'll have heard that message come through time and time again. Okay, let's give ourselves, we need to step away for a few minutes, just step away from the screens. Let's take a break. I will see you at, let's say, 14:22. We'll be back at 14:22, and let's just thank Malcolm and Jen, and in absentia, Alan. Thank you. I'll see you all 14:22. Don't leave the meeting, just switch off your cameras. We'll be back in a second. Brilliant. Okay, so welcome back to this session. And we're going to start off by talking about trial steering committees and charters, and I'm going to be giving that presentation, and I'm going to be doing that live. So let's see how this goes. I've got a few slides here. Hopefully you can see my slides in slide format. If anyone wants to put something on the screen reaction wise, just to let me know, that will be reassuring. Okay, perfect, very good. Okay, So trial steering committees, as we use them in the UK, as a couple of people have shown you, came out of the old MRC Good Clinical Practice Guidelines for clinical trials that came out in '98. And they define the trial steering committee role as one to provide overall supervision for the trial, should provide advice through its independent chairman, the PI, what for many trials we call the chief investigator these days, the MRC and the host institution. This predated sponsorship as a word. And they say that it should involve independent members who are not directly involved in other aspects of the trial to provide protection for trial participants and the PI. They had a whole section 6 was about the independent supervision. So for example, in 6.1 they mention a trial steering committee and an independent data monitoring and ethics committee. Generally the MRC, like those of us involved in Damocles, would use independent data monitoring committee these days, but you'll have noticed a range of terms going past today, and it's like talking to American, and it's a tap faucet thing. We just pretend we hear the right word. Right, we've got our little Babel fish in there. Trial steering committee, we often tend to use that one word for it. They talk about data monitoring in 6.4, and they don't mean monitoring the way that very often we use monitoring. And some of you may find it interesting to read Sharon Love's new paper in Clinical Trials that came out last month, talking about terminology around monitoring and what might be helpful. They talk about in 6.6 the progress of the trial, that it's a role of the TSC to monitor progress and to maximise the chances of completing within the timescale. I wonder how many of you took that approach in the discussions before lunch. And they talk about dissemination, which I think is important, and implementation. TSC should ensure appropriate efforts are made to ensure, look, two uses of ensure in one sentence, the results of the trial are adequately disseminated and due consideration is given to implementation of the result. So they suggest there's a role about implementation, which is a little bit further than I think many of us will go these days. Anyway, you may get the impression that the MRC Good Clinical Practice Guidelines have been withdrawn, and they have been. They disappeared a few years ago. MRC no longer really funds late phase trials or trials in the UK, but they do fund global health trials, and the guidelines for oversight are now in their global health guidelines that you can find online. The link is below, and the concept is updated a little bit, but it's broadly the same. I'm not going to read these out for you. You can just see that the terminology has just sort of been updated, for example. They mention more explicitly the use of a charter, and that wasn't in the 1998 booklet. Many of you will know your way around charters these days anyway. A charter aims to clearly set out the roles, the responsibilities, the processes. You heard talk about going to process, sticking to process, structure and communication, and I think importantly what to do in difficult situations. And there are template charters available. And actually using one template charter or a small number of template charters from which to start is really helpful for consistency of information. We know that even if the details of implementation are different, it's then quite easy to pick up the charter for this committee and see how today's committee differs from yesterday's committee if you're sitting on something different. So that consistency of presentation is helpful. This is the template TSC charter that we use at the MRC clinical trials at UCL. Got a blurby front page on the left, just our instructions to ourselves. We delete, we update everything that's in yellow, bright yellow, and then we remove, once we're finished with it, anything that's in green, our guidance text. But this format of sort of question on the left and answer on the right, this columnar format, I think is really helpful. This is very similar to our IDMC charter template, and that's no surprise. It's been lifted directly, the questions that we ask to the TSC, from the IDMC to the TSC charter. And that's because when we started using TSC charters, we didn't have any dedicated research. We didn't have the research that Carol and Athene with others have led on. The IDMC charter comes out of the Damocles work. This was an HCA NIHR funded project specifically on data monitoring committees. This is a summary paper that came out in the Lancet in 2005. I was lucky enough to be involved in that as a very young researcher. And one of the outputs from this was a charter. This green document here, you can vaguely see this columnar format was there. The charter launches out from this, and the template charter that I showed you for MRC CTU very much follows the same questions, same guidance, plus we've got our own sort of specific guidance that's in there. So for example, there's sections rising from this DMC charter on trial details, roles and responsibilities, what to do early in the trial, the composition, members and independents, setting out relationships, organisation of meetings, documentation, confidentiality, importantly, communication, decision making, reporting, and what happens after the trial. And so we're very happy to share our implementation. I know that others will as well. It's good that many or most of the UK trials units, I think, are using this template. So setting out the relationship is important, and I think we used to explicitly quite acknowledge that the Data Monitoring Committee provided feedback through the trials unit. This version tried to colour coordinate who was on which committee. You can see this kind of Neapolitan ice cream of an approach here for TSC, showing there's people from the trial management group and people from the trials unit on it. But we stopped using this particular diagram when someone started saying that it looked like the trials unit was wearing a pair of Y-fronts. So we stopped using that and moved to this approach, which really says the same information. But having grown up coming home from school in the 80s and watching blockbusters, I have a penchant for hexagon-shaped things. So we now have this diagram that we tend to use. But this does set out the relationships. Important here is setting out who is primary in decision making and what to do in difficult situations. What do you do if there's disagreement between the TSC and the IDMC, or even between members of one of those committees? Much better to think about that up front and almost have a standard approach. Is there an extra committee? Does what the TSC says goes? You don't. Well, I mean, I saw at least one example being discussed at the Society for Clinical Trials maybe 10 years ago now, where the TSC didn't accept the IDMC recommendation, so the IDMC members all resigned. That doesn't seem ideal. What do you do in that situation, and how do you make up for that? You put something in your charter that sets out how you avoid this. So there are template charters, and you don't need to start with a blank page. You can start from standard answers, there's guidance text, and you can start from the previous trial in the area if you think it will be helpful. There may be default text to follow and constraints required by your specific sponsor and your specific funder for that trial. And the first draft can be done by the trial manager or the project lead and then presented to the committee. The TSC, the independent members, shouldn't have to write this. They should get to comment. It should be agreed by the trial team and the TSC members. You circulate it before the first meeting. And either agree it beforehand or do it at the meeting if you can. So could we update the template charters that are being used for TSCs based on that recent research? Well, yes, we can, and that's a work in progress. We can use some of that new information. And updates should cover more information about PPI, because that wasn't such an issue back when the MRC originally wrote their documents, and even PPI it's not the involvement in data monitoring committees hasn't been there. So this is new, and we can draw in Jen's guidance on this. The role as observers and the input from non-independent members in decision making or contribution is important here. Remote meetings, the current charters often talk about in-person or teleconference. Well, actually, video conference is a different beast. Mark spoke to you about some of the challenges of that, but I think those are quite different. Umbrella committees, TSCs, I think are more likely to cover more than one trial. Well, how does that work out? Maybe we'll use the opportunity to encourage a name change that we set out in the paper that Athene and Carol first authored jointly in 2019, emphasises semi-independent nature. We put independent in the front of data monitoring committee, whereas this is a semi-independent committee, and maybe use oversight rather than steering, because lots of countries call a trial management group a steering committee, so it just confuses people outside the UK. There are other updates going on that we need to account for too. The MRC is currently updating its own guidelines on trial steering committees. That's work in progress. Carol and Athene and I are just about to comment on this. They are including clarification of membership and clarification of independence, and I'm encouraging them to talk to the NIHR as well. Really important that funding bodies talk to each other, please. And they're going to talk about proportionality and oversight of lower risk trials, how maybe you can decrease the oversight where it might be relevant. Mostly I've been thinking about late phase trials today, and a few of you have talked about how do you do this in early phase trials. Early phase trials, I think, are a completely different beast when it comes to oversight. ICH, the International Committee for Harmonisation, is updating their guidelines at the moment. So E6 will be reviewed and probably out next year. Will oversight be mentioned? I'm unsure. Will TSCs ever be used outside the UK? If there's such a good idea inside the UK, why aren't they used more widely outside? Or if other people don't need them, why do we have them at all? It'd be great if ICH came to conclusions on that. The Gates Foundation and Wellcome people running the Good Clinical Trials Collaborative led by Martin Landry from Oxford. They're developing guidelines, and will oversight be mentioned in that? Well, I hope it will be. I'd be foolish not to drop 3 quick adverts in here if you don't mind. If you've found today's course interesting, UCL has finally set up dates for its online version of the Independent Data Monitoring Committee course that's run, usually 1 day, but this is going to be 3 afternoons. That's just opened up. Trials has a call out for papers at the moment for case studies of experiences with interim data, particularly data monitoring committees, but that could be other oversight committees. Doesn't have to disclose anything about a given trial. We'll find a way to work with you. I'm editing that, and so if you're interested, drop me a note, or if you think there's an interesting story. Mentioning trials, they've also got an advert out for a protocol editor, probably for a good trial manager or somebody operational who knows their way around trials and try and help make sure that trial protocol papers are published swiftly. That's the advert breakover. Thank you for indulging me on that. If I may summarise, we can use a charter to clarify the role of a trial steering committee. You can use this to ensure that responsibilities are clear, and it's really important to avoid any unnecessary duplication of responsibility for IDMCs. These committees tend to blend together, and sometimes funders encourage it, but your recruitment problems, that's a responsibility of the TSC. The IDMC sees this for context. Your issues with follow-up and data return rates, that's for the TSC to comment on. For the IDMC, it's context. Do they understand the data? Keep them separate. Okay, really important to do that. Embrace the existing charters and embrace the forthcoming updates, please. So that's everything that I wanted to cover for the purposes of sharing on charters. I hope that's helpful. So with a view to the next session, I hope you found the first breakout useful. We're going to go into the next breakout session in a moment, and we're not going to chair those. We're going to put you in small groups, and we're going to allow you to chair those yourselves and come back to us as what you do with a recommendation. And I would like very briefly just to pick up on a little bit of feedback, a couple of thoughts I had, again, if I may, from the session this morning. I know a few of the groups managed to put their responses in, but not everybody. And for the 4 groups that put in, I think they were broadly aligned, which is great. I think really helpful. But one of them asked about, they wanted the IDMC's views about that change. And if we think about the separation of the IDMC and the TSC, I just would take the opportunity to mention this. They ask the IDMC, who has already seen potentially accumulating comparative data, to comment on a redesign of the study. And I think that's dangerous. I think the whole point of having the TSC is so that you've got someone that doesn't know the accumulating results to comment on the protocol change. If you're going to ask the IDMC to do it, then you don't need a TSC. The whole point of the TSC is to have someone that doesn't know. The IDMC shouldn't be involved in this. If they've said continue, that's fine. There may be something they need to release about event rates on the control arm, but it's not their responsibility to do this, and we need that clear separation. So I felt like I just sort of didn't feel I could condone this statement, this agreement from group 3, really. Others may disagree, but I felt quite strongly about it. So they asked whether a futility analysis was planned. That's not for the IDMC to decide. That's for the trial team as part of their design to come back on. Okay, so while I'm sharing that screen, why don't I try to show you very briefly the scenario. Claire has put it in the chat, but the scenario is you are the chair of a trial steering committee. Imagine this: you are Professor Aaron Aronson, chair of the TSC for an NIHR-funded University of Warwickshire sponsored fantastical trial. You've just received a letter from the chair of the IDMC after their most recent meeting. So what are the next steps, and what should you do, and with who? So, and are you happy with the recommendations that you get? So you've got this letter, work through it together, maybe share screens one if you want. It's a short letter, and once you've got your thoughts, drop them into Padlet, just put some comment at the top and run through there. So if there's any clarifications, start to bring those up, and otherwise I think Cormac and Claire are about to start to put you into the breakout groups, and that takes a minute or so to do, I think. And you need more information. Needed more information before making this decision, right? That imbalance in data, I think was a little bit concerning. And maybe it's best not to reveal anything to anybody yet till you've got that clarification. That could take a few months, and a few months is better than a bad decision, I would think. And then when you do have the information, who do you tell? At the moment, it looks like you can ask the unblinded statistician or the IDMC chair things without unveiling anything at all. Whereas actually, once you start telling the chief investigator anything, then you've potentially lost any protection that you've been offering them. The same with other members of the trial team. So, I think the next port of call to discuss anything is with the independent members of the TSC, and continue to protect the non-independent people for as long as you can. I think is a good idea. And the fact that you didn't have any quality of life data at this stage, to me, doesn't make me too anxious, because you had a convincing convincing efficacy signal, not too much in the way of safety. You can report on PROs later on. I think that's not to denigrate those, but often this is a cracking improvement in survival and no safety signals. Patient-reported outcome measures aren't going to make too much of a difference if we're honest at that interim stage. But the lack of long-term follow-up is a bit bothersome. Yet we all signed up to that in sitting on this data monitoring, on this trial steering committee. We'd agreed to that. If you didn't like it, well, you should have thought about it a few years ago when you signed up, right? Which I think is rather interesting. Anyway, any other thoughts? Put them in the Padlet. And we've got some other questions that we wanted to pick up on. So Athene, in terms of questions, I don't know if you've had a chance to be monitoring the Padlet. Are there particular questions that we wanted to pick out that we've not covered so far?
What we want to do is do the poll. The voting.
Should we do the poll now? Brilliant. Let's do the poll.
Poll, if you don't mind. So
perfect.
If we can do the poll, I'm happy to read it out, but hopefully Cormac is going to whiz it up on the screen. Here we go. So press your buttons now, folks. It's all anonymous. So would you be more likely to accept the role of the TSC chair after this workshop? So strongly disagree, disagree, neither agree nor disagree, agree or strongly agree. So press 1 and press submit, and then hopefully we might be able to get it before the end. Otherwise we'll feed it back via an email. So have a go now, and then we will do some of the questions, the Q&A that is on the screen. We've got a few more that have come in.
So 3 people left to vote, yeah.
Okay, I don't know how instantaneously we're able to obtain an answer. It's all new news for me, but anyway.
So 1 person not voted. I imagine they're all there. Amazing. Can the attendees see that, Athena, or is it just us?
I don't think I can see anything. I think you might be in charge of this this exercise, Matt, because I can't see.
Then I will click on.
Oh, there you go.
End polling. Can that be seen on screen? Can I do, or what happens for this, Cormac?
Yeah, everybody should be seeing that on screen. Oh, hang on.
Not here. I'm not. Aha, here we are. Go. Yeah, got it. Okay, so 41% agree, 22 strongly agree, 30% kind of in the middle, and a couple disagreed. Obviously, managed to put everybody off, a few folk off. Okay, Matt, so you're the
That's not necessarily a bad thing, is it? I don't think. If a couple of people have said, yeah, unless you've made it too horrible today.
No, that's right. So anyway, so that's all of that. So that was just, well, kind of a little bit of fun, but also interesting to know whether people's views had changed. So we're now going to pass over to Matt, still in charge, but looking at just any final Q&A that we've got, because we are going to finish at 10 past. I'm just going to have a few words. So we will finish by 3:15, confirmed.
Yeah, so let's see what we've got in pressing questions. So there's a question here about what do we do if the TMG lose their faith in the TSC chair? So what if the TMG no longer believes in the TSC or thinks their actions aren't acceptable? That does sound like a difficult situation, doesn't it? What do we do in that instance? I wonder, is Carol still with us? Has Carol had to run off to her funding meeting? Carol, you're still with us. Carol, do you want to give us some thoughts on that?
I think there are occasions when you become maybe you question the level of engagement of the TSC that you have, and I think that's fair enough, because I think when you're appointing your TSC, you really do want them to not to grill you per se, but to really drive and push your motivation and your thinking in terms of delivering the study as well. So if you're feeling that they're disengaged maybe, or that the suggestions that they're making are maybe stem from the underlying agreement with the initial design of the study, then it does bring in some difficulties. And I think you've either got to have that conversation with the chair, so the chief investigator and maybe some lead members of the CTU have that discussion with the chair. But I think you may also need to feed back to the funder on that you're having some difficulties and you'd like their guidance on it as well.
Yeah, I think it's really important. I've been involved in a trial where one of the IDMC members was consistently not attending, and we sort of operated a 3 strikes and you're out, or 2 strikes, and we escalated, had a conversation. They promised to turn up, they couldn't turn up. And eventually we just rotated them off. We did it in a very constructive way. It's not ideal. This sounds, in the way the question is phrased, like it's a little bit more antagonistic, doesn't it?
I think one thing that I would say is though that we've all got too much reliance on email. People's email inboxes are generally just, an email sent is not an email read. And so if you've got a TSC chair who's not responding, maybe try and phone them, or ask them if they've got a PA, or ask them if there's an alternative email address that you could use for them, just so that they're not missing the important emails relevant to the trial, rather than just assuming it's the level of disengagement. So I think we need to kind of like think about things in terms of how we're communicating with the TSC chair, as well as kind of like what the TSC chair is giving back to us.
Yeah, I think that's really good. Okay, so Theanine, there's a question about that sometimes people from academia sit on a trial steering committee for industry-funded trials, or whatever the oversight committee would be called in that particular instance. Do you think it's problematic for industry people to sit on academic trials? Is there really issues in that, or where do you think there is an issue, and when is it fine?
I think, in principle, like all, if they are an independent member, and as was mentioned earlier, I think Birgit mentioned, it is more about the expertise and the conflicts of interest, but we have got to be clear and manage and acknowledge and work with the transparency and conflicts of interest. And I wouldn't say I've had experience of that. I've had experience of co-funding of, say, piece of equipment within a trial where we didn't give that person, that company, any real leeway into the trial, and it did cause us sort of problems in terms of reporting. We always had to write that up, etc. Conflicts of, then the chief investigator was invited to a meeting. I know I'm rambling, I'm going to stop rambling. A paid-for meeting. We told him he couldn't go. So I think for us, we've tended to steer clear of that approach just to make for a simple life. But I take Birgit's point that if that's where the expertise is, there are very good statisticians working in the pharmaceutical industry. I would go after them if I thought that was the place to go.
Yeah, okay, that's really helpful. I think that's really important. Yeah, if you're not assessing something from the company or from their competitor, then there shouldn't be too much of a conflict potentially. So I just wanted, maybe we should make this a final question for the purpose of time. Sitting on data monitoring committees, sitting on trial steering committees, although the emphasis of responsibility is different, how different does sitting on each of those committees feel? I wonder, Pete, we've still got you with us. I wonder whether we might be able to ask you that first. Does sitting on a trial steering committee feel very different to sitting on a data monitoring committee to you?
It does. So I think I much prefer TSCs. I think they're more, I suppose partly because they're more expansive in their scope. There's more, to me, room for discussion, whereas the DMC feels a lot more procedural and structural. So yes, I think they're very different, and I would always prefer to be on a TSC, partly because I'm a very sort of generic methodologist rather than a statistician or a clinician. So I'm interested in the broader picture. But
so that's really helpful, Pete. There's a really important thing for anybody thinking about what their membership is. Think about the skill set, and how comfortable it is when you're assembling a TSC and the members. I think that's really important. How about you, Carol? Does sitting on a TSC feel very different to you to sitting on a data monitoring committee, and in what way?
It does, because you're not going to be looking at that comparative data. So in some ways, you see less information than you would in the data monitoring committee. But having said that, I'm a statistician, but I've also got interest in trials methodology. So sitting on both has you know, allows me to see kind of like both sides of the coin for different trials. And it really depends when I'm being asked to go on one. You know, what do I foresee as the interesting challenges for that particular trial? And it might be that the most interesting challenges stem from recruitment or retention, rather than necessarily the kind of the design in terms of their interim analyses and so on. So there are differences, and you do see less information, you see different information, and the discussions can be quite varied as well.
That's really good, thank you. Athena, do your thoughts broadly echo that, or do you?
I think they do.
Feel similar?
Not because I've sat on a DMC, I've always steered well clear of that, but the TSC experience I've had, I like the TSC because it has that broad remit, and it also brings together a broad range of expertise. And I think it is the one time with my CTU hat on where the chief investigator really gets a chance to go up against some independent experts. And harking back to one of those questions, it can be a little bit of a wake-up call for the chief investigator on occasions. And actually, as a CTU, we quite like that sometimes. And it is a good, open, honest debate. So I think that's why I like the TSC. It brings those parties all together in, well, one room or one virtual room, depending on where we are.
I think that's fair enough. I find the TSC a more difficult committee to sit on. That's because I think it's that lack of knowledge about what's actually going on in the accumulating data. I almost find that a bit more difficult not to know, and I rather enjoy sitting on data monitoring committees. So I enjoy sitting on both committees actually. I think it's a fascinating challenge. And just always really enjoy doing them. But I felt I wanted to sit on a lot of data monitoring committees before I sort of felt ready to sit on a trial steering committee. I felt that it just sort of took me through in that way. I feel it's a more difficult committee. I was chatting with people the other day about whether trial steering committees are as scary as they used to be. I don't know if that's just about me moving through my career, but I think that critical element I think maybe needs to be the stringency of independent people. We need to remind the chairs sometimes that maybe they do need to be really pushing the trial team in that considerate, gentle, but actually really, when required, forceful way. Anyway, I'll stop talking at this point. I'll say thank you very much to everybody for engaging today. Really appreciate the questions, and very conscious that we didn't manage to get through absolutely everything. But I'm going to hand back to Athene. Athene, over to you.
Thank you. Well, I'm really just going to do the thank yous and wrap up. And really, I'd just like to say thank you very much, first of all, to the participants today. I think it's been a really interesting discussion. Well done, everyone, for hanging on in there. Obviously, of course, I'm going to thank my organisers with me, Matt, Carol, Claire Clement, who's been in the background here, has been a researcher and has absolutely led from the front here. Couldn't have possibly gone on holiday if she hadn't managed to hold the fort very effectively. I do give a big up, or whatever the phrase is, to Cormac of Staunton Media, and if you're organising one of these conferences, place to go. And then finally, of course, I would like to acknowledge the funding that's been received from the NIHR, and that's in the CTU Clinical Studies Unit's Funding Efficient Studies Call, which wouldn't have been possible without that funding. And also thank you to all the speakers who've really made it. I must say, I've learned a load myself, and I thought I've been doing trial steering committees for some years now. So many thanks to everybody, including our stalwart PPI member, Malcolm Pick. So I think that's all. I think just nothing more to say, except hopefully you found this a very useful occasion. We've kept the Padlet. I think some of our next steps are to try and revise the terms of reference to bring it up to date, as Matt alluded to, working with the MRC, hopefully, so we can bring some of this good practice together. I will just say we will be sending around a feedback form, which I very much appreciate folks to chip into. We have recorded this, and we will probably, possibly, hopefully find some way to make some of these materials available, or indeed repeat this course, rather like the Chief Investigator's course. It has been repeated because hopefully there's valuable information here that others might want to hear on another occasion. So once again, many thanks to the organising team, Matt, Carol, myself, and Claire, of course. We were the main ones, as well as Cormac, and thanks to you for joining. Any final words from Matt or Carol before we go?
No, none from me. Just a thank you for everyone and for everyone's contributions today.
No, Matt doesn't have a nugget to add. So on that happy note, we've finished 2 minutes early, which I think has to be a record for some of these workshops. So anyway, go out and enjoy whatever sort of sunshine you've got or whatever. Please fill in the feedback form, and hopefully you've enjoyed this workshop. So thank you for me, and goodbye.